clinician. So we can start, and from Bucharest we'll go to New York, and I'll introduce Dr. Barry Smith. He's the director of clinical simulation education at our program. He's an experienced physician with training in critical care and ER. He's having experience in Army, a lot of first line, and he was nice to us with the whole presentation, put it all the education material for us, and he will start presenting our department from Queens, New York. You are on, Barry.
Good morning, Romania. How are you? You all look great.
It's interactive, I told you. So interactive, friendly and interactive.
Bun venit. Welcome to New York. And I want to say bun venit to Dr. Beatrice Mailer, the medical director there, and also all of the team at Marius Nasta Institute of Neurology. New York City, a city of 8 million with 5 boroughs. New York City Health and Hospitals, Queens, is a member of the NYC Health and Hospitals Corporation and an affiliate of the Mount Sinai Icahn School of Medicine. It's a major healthcare provider in the borough of Queens that has proudly served the communities of central and southeastern Queens for nearly a century. Medical services here are provided through an affiliation agreement with our academic partner, Mount Sinai School of Medicine. We offer residencies in dental medicine, internal medicine, OBGYN, ophthalmology, in addition to fellowships in pulmonary medicine, gastroenterology, endocrinology, and nephrology. We offer a high level of clinical education to approximately 75 internal medicine residents, and these residents are very diverse, coming from over 40 countries, reflecting our patient population. The NYC Queens Medical Simulation program is part of a larger program of the 11 acute care hospitals we have within New York City Health and Hospitals. Each hospital has its own satellite simulation program for education. The simulation program here offers a multidisciplinary center, meeting the demands of the internal medicine department and other training programs. It's meant to enhance the quality of healthcare delivery and patient safety by using a full spectrum of assessment tools, which ultimately the benefactors are our patients. Our mission statement is to promote quality and safety, enhance education and training, and develop research through excellence in simulation-based training and assessment. We have 4 core values. Those are to promote and respect cultural and racial diversity. 2, to demonstrate ingenuity and promote self-reflection on practice to improve clinical processes and hospital culture. 3, to focus on improving cognitive, psychomotor, and behavioral skills while maintaining psychological safety. And 4, to promote multidisciplinary collaboration between all departments and enhance teamwork that it elevates medical training. We have many goals and many objectives, but the bottom line is we're trying to enhance our education, improve our effectiveness of the residents and efficiency of all of our residents. This is a Kirkpatrick model and Phillips model of simulation, where in medical school, we gain our knowledge as novices, and then we go up the ladder where we interpret and apply what we've learned, and then we demonstrate it. And in simulation it provides an opportunity to demonstrate that knowledge that we've learned and acquired in a safe space. So we don't practice on our patients. We practice on high fidelity mannequins, and that promotes safety in healthcare. From that, we hopefully go to performance in practice and we become experts in our field. So that's what we hope to gain. We have a whole list of faculty, which incorporates respiratory therapy, as well as nursing, and all of our clinical specialists, and Dr. Theo there as well. This is our simulation room, which has a high fidelity mannequin with many task trainers. And we recently purchased a high fidelity intelligent ultrasound platform to the right, which has been instrumental for teaching our residents in POCUS the bedside ultrasound. Our residents gain lots of experience in simulation through didactics as well as hands-on practice. Here you see them practicing clinical medicine, and I firmly believe in the see one, do one, teach one way of practicing, where our upper levels supervise our juniors in gaining skills. We also have a virtual platform, which the residents are very excited about taking it into the future. And we practice in all environments, in conference rooms and in the lab. Our curriculum is wide ranging and includes advanced airway skills, mechanical ventilation, paracentesis, thoracentesis, lumbar puncture, virtual simulation, as I just said, point of care ultrasound, central line placement, and debriefing. As far as debriefing, we use the Pearl method of debriefing, which integrates 3 educational strategies. That is learner assessment, 2, focused discussion, and 3, we provide information in the form of direct feedback in teaching the residents. This is our team of our clinicians here. We practice both in the lab as well as in situ on the floors and in the hospital, which we bring together the nurses, the respiratory therapists, all levels of residents to practice. And to that end, I want to show you just to give you a little taste of what we see in one of our in situ simulations.
Keeping time? Yeah. How many minutes are we in the code? So 2 minutes. 2 minutes already in the code? Yeah, because we started to 3. Okay, then stop for both. Stop.
This is a patient that had digoxin toxicity and hyperkalemia, unrecognized and arrested.
Okay, Ms. Lopez, you're going to keep time and you're going to check when the next epi is.
These simulations are meant to promote our communication between the nurses and doctors, giving report.
Submitted for diagnosis and agent with RDR. Overnight, patient was assessed by cardiology who recommended initiation of the doctor. Hospital was placed for nephrology to see the patient this morning. The first year resident started goal-directed medical therapy for heart failure with Nasta, Lasix, Relacto, Jardiance, and Digoxin. Overnight events where the patient was loaded with Digoxin and above medications were started. 6 hours after initiation of medication, patient began to complain of severe abdominal discomfort associated with nausea and persistent non-bilious vomiting. Patient also complained of change in vision. Also no urine outflow overnight.
Our evaluators include our critical care nurse manager, as well as you see Dr. Theo, critical care intensivist, and other intensivists to give direct feedback to the residents. What do you have on the monitor? In these simulations, we promote the team leader assuming control, having a wide view of everything going on the patient, so they advance their abilities.
While it's charging, we're going to do this.
Charge 120. Everyone clear?
Okay.
Everyone clear?
I think that just gives us an example of one of our in situ simulations. So it brings us to today, our mechanical ventilation seminar of the American Eastern practices. Again, I thank you, National Institute of Pneumology, Marius Nasta Hospital, for giving us the opportunity. Our objectives here today is to, 1, review the principles of mechanical ventilation, 2, improve critical thinking and problem-solving skills, 3, to demonstrate ability to troubleshoot and manage various respiratory conditions, and 4, to demonstrate ability to adjust ventilator settings to achieve optimal patient outcomes. So with that, I want to turn the program over to Ms. Matthew, who is one of our supervisors. You can come up. Camille Matthew, one of our supervisors in respiratory therapy. She's outstanding respiratory therapist, as well as our respiratory educator. And through today, we'll be doing didactics. And at the end, we're going to have fun doing multiple simulations where we will test your abilities. You will be the virtual doctors, and you will be treating a patient that comes in and over time gets progressively more sick. And that will be quite exciting. So, Matthew.
Good afternoon. Just 1 minute. Okay, so good afternoon again, everyone. So I'm going to just go into the intro to mechanical ventilation. Some of the topics that we'll discuss today is starting with oxygen therapy, most specifically high flow nasal cannula. And then we're going to venture into mechanical ventilation, where we'll discuss the indications for mechanical ventilation, physiological principles of ventilation, and types of mechanical ventilation. So we'll start off with oxygen therapy. So here at this facility, we started to use a bit more of high flow nasal cannula, especially since the pandemic, and it's been really helpful for us. But with that particular device that we use, specifically, we use the Airvo 2, and that's what you see in the picture to the right. We're able to provide FiO2s from 21 to 95%. And we can give flows from 10 to 60 liters. So you're probably wondering, well, how can we give that high amount of flow and have the patient comfortable on that increased flow? Well, we also provide humidification with that device. And the temperature range goes from 32 degrees to 37 degrees. The warmer, the better, the more comfortable it is for the patient. Okay, so when is it recommended? So it's recommended to improve oxygenation when the patient is in hypoxemic respiratory failure. We may improve ventilation by flushing the upper airway dead space of CO2, therefore decreasing the minute ventilation. And a lot of studies have shown that there are some therapeutic effects of high flow nasal cannula that relates to the CPAP effect with an approximate level of about 3 to 5 centimeters of water. Okay. So now, if we initially start with the patient on high flow nasal cannula and we see that they're not doing well, we will have to make a decision. Where do we go next? So the decision might be, well, we may have to apply positive pressure ventilation. So you guys may be familiar with this ventilator on the picture, which is our Draeger 500 ventilator. That is what we use throughout this house over here at Queen's Hospital. So going into just the basic purpose of mechanical ventilation, just a little review. So ventilation is what we are doing right now. We're bringing in fresh air for gas exchange into the lungs, and we're allowing for the exhalation of air that contains carbon dioxide. But when we have those patients who's not able to sustain that same level of ventilation that's needed to maintain gas exchange, we have to provide and also maintain oxygenation. So that's when mechanical ventilation comes in. So just a little review on what happens during positive pressure ventilation. So as the mechanical ventilator delivers that breath, it will move air into the lungs. either by an endotracheal tube or a non-invasive mask, depending on what device we are using. And then we are also maintaining adequate levels of partial pressure of oxygen and also partial pressure of CO2. And in addition to that, we are unloading the inspiratory muscles. Okay, so just a little bit in the mechanics of what's happening. So during inspiration, the alveoli progressively builds and becomes more positive. The positive alveolar pressure is transmitted across the visceral pleura. And then that in turn creates the intrapleural space to become more positive at the end of inspiration. So I'm just going to skip really quick to a diagram that I have here. And if you look on the left side, during inspiration, you have positive pressure coming in. And if you notice in the intrapleural space is positive, and in the alveolar space is also positive. So now we're going to switch back to the end of inspiration. So the ventilator will stop delivering that positive pressure breath. The mouth pressure will actually return to ambient, 0 atmospheric pressure. And the alveolar pressure is still positive. So what happens is the gradient between the alveolus and the mouth allows the air to freely move out. So we'll go back to the diagram again. And if you notice right here on exhalation, atmospheric pressure is 0. Intrapleural space is negative pressure, but the alveolar space is still positive. So the gradient between allows that air to slowly free out. Okay, so let's go into the types of ventilation. So you have your two main types, invasive and non-invasive. What's the difference between the two? So when we're providing invasive ventilation, we're providing that through an artificial airway. Oral or nasal endotracheal tubes. Most of our patients here are orally intubated. We sometimes have patients that's nasally intubated. It could be someone who comes in with angioedema, or maybe they went in for a particular surgery that caused them to be nasally intubated. And that usually happens maybe a few times a year. And then we also have the tracheostomy tubes. We do get a number of patients who are either placed with a tracheostomy here at the facility, or they come from another facility with the tube already. And then you have non-invasive ventilation, and that is provided through a mask or some other type of non-invasive interface. What we mostly use here is a full face mask, and I have a picture to show that in a moment, nasal mask, and then a total face mask. And the three different modes that we use primarily here is BiPAP, CPAP, and also AVAPs. So this is our BiPAP that we use here. It is the Respironics V60. That is our go-to device for non-invasive ventilation. So let's just go into some of the indications. So for non-invasive ventilation, we may be presented with patients with acute respiratory failure, acute or chronic respiratory insufficiency, acute hypercapnic exacerbations of COPDs, difficulty weaning. We do have that sometimes in our ICU where when we're struggling to wean a patient off of a mechanical ventilator, usually the decision is made by the attending, well, let's try BiPAP and then see what happens. So we do get that quite often. And then sleep apnea syndrome. We get a number of patients who are diagnosed with sleep apnea. And when they come here for possibly other reasons, if they are diagnosed with sleep apnea, we still provide just to kind of maintain what they use at home. So now we'll go into the contraindications. This is so important because if a patient presents with any of this, the decision from the residents should be, okay, this is not a good option. We have to go to the next level. So number one is if the patient is incapable of maintaining life-sustaining ventilation or they are apneic. They're unable to maintain a patent airway or clear their own secretions. Someone who's at risk of aspiration. History of allergy to the mask material. Even though our mask is latex free, but you may have patients with maybe sensitive face or, easily allergic to anything that may be touching the face. Facial trauma, because these masks are a little bit added pressure to the face. And then someone who's coughing up blood. Hypotension and claustrophobia. So those are our contraindications for non-invasive ventilation. So now we'll go to the non-invasive mask. So starting with our number one that we use here in the hospital, that is our full face mask, and that covers the nose and the mouth. But sometimes we have patients who are diagnosed with sleep apnea and they're familiar with using just a nasal mask that just covers the nose. So if they do ask, we provide it for them. And then the last one, we don't use this as often, but it is available, which is the total face mask. Who do we reserve these for? Patients who are prone to breakdown, especially right here at the bridge of the nose. We use that to just alleviate the pressure from those pressure points on the face. Okay, so now let's go into modes of non-invasive ventilation. So starting with our BiPAP, that's like our number one mode here, bi-level positive airway pressure. In this mode, it is patient triggered, pressure targeted, and flow or time cycled. So we provide two levels of pressure with this mode. There's your inspiratory positive airway pressure, which is called the IPAP. And then you have your expiratory positive airway pressure, which is your EPAP. And the difference between is your pressure support. The higher that number, the easier it is for the patient to breathe. They'll get higher tidal volumes. They have lower respiratory rates. So we always look at that and kind of decide, okay, should this patient benefit from a higher pressure support or lower? And then we also go based on the blood gas. So if an ABG shows an increase in CO2 after a patient has been on BiPAP, we might make the decision to say, let's increase that gradient between, which is the pressure support, to help blow off some more of that CO2. And then going to CPAP, continuous positive airway pressure. That is one level of pressure. And the patient just breathes in and out, determines their own volume, determines their own rate. Mostly reserved for those patients who are diagnosed with sleep apnea when they go in for a sleep study. Most patients are placed on CPAP instead of BiPAP, and depending on their level of sleep apnea will decide on how high that CPAP level should be. So let's go to the waveform really quickly. So right here on top is your CPAP waveform. So as you can see, you have one level of pressure, and this is the patient breathing in and out. Okay, but when we go to the bottom, which is our BiPAP waveform, you'll see the patient will inhale to inspiratory pressure, exhale to expiratory pressure. And the difference between these two is your pressure support. Okay. So the next mode is AVAPS, average volume assured pressure support. This mode has become more popular here in our facility. My staff, they're starting to use this a lot more, and they're actually making decisions and trying to like convince the residents to say, hey, let's try AVAPS on this patient because what we have right now is not working. So what does it do? It delivers an average target tidal volume by modifying and regulating the pressure applied. The breaths are time cycled, mandatory breath, and pressure supported spontaneous breath. But during an AVAP setup, there may be a period of time before the target tidal volume is achieved. So what happens is my staff, usually when they set the patient up on AVAPs, they have to give it time because it's not like the ST mode or BiPAP mode where once they set the pressures, okay, you'll see right away what the tidal volumes are. With AVAPs, it progressively starts to increase. So it will look something like this. As each breath is taking place, you notice you get your increase in volume here at the bottom. So it takes time to actually achieve that target volume that you'll want from that patient. When you look up here at the pressure, once we get to that volume, it's basically locked in between your max pressure and your minimum pressure. Okay, so where do we start first? We start by deciding what would be the target tidal volume for that patient. Once we set that, and we'll probably set a max pressure of what they were on BiPAP, and then see how high do they go under pressure to achieve that target volume. So that's why I said it does take some time, maybe even more than 5 minutes, maybe a total of 10 minutes, just for them to actually see what the patient is capable of doing. And that's when we get the doctors to put in the order for that. So I have a little picture of a patient that was actually on AVAPs, and one of the residents actually shared this picture with me because he was concerned with, okay, the patient is set at the target volume, we have our pressures locked in, but the patient wasn't quite reaching that target volume of 330 mLs. And then the peak inspiratory pressure was already at 25. So all up here is what the patient is doing. Down here is what we are setting. So the first thing I looked at was we had this leak over here. So this machine is really good with calculating the total leak. And a leak of 65 is really high. We like to have that number 35, 40, no higher than that. So my question to him was, well, did the patient have an NG tube? And he said yes. And that's where the leak was. Also, when I spoke to the staff member who was setting it up, he said it was literally less than 5 minutes that he had it on the patient. So we had to give it time. But this is just to give you an idea of what AVAPs look like. At the bottom, you have your target volume. We still set an EPAP pressure. And once we get to that target volume of 330, we basically lock it in place with that minimum pressure and the maximum pressure. So when is it time to terminate non-invasive ventilation? So when the patient is not getting any better, the pH and the PCO2 and the blood gas is getting worse or has not changed at all. Patient is still tachypnic, hemodynamically unstable, saturation is less than 90%, decreased level of consciousness, or just inability to clear the secretions or tolerate the interface. So I'm just going to share this algorithm that I had developed for the residents, and it's kind of a go-to when they're kind of stuck on deciding, should this patient go non-invasive or not? And it also lists the contraindications. So it walks them through deciding, is this patient presenting with a hypercapnic respiratory failure, or is it going to be a hypoxemic respiratory failure? Sorry if it's a little hard to see. But then it will walk them into the contraindications. And once they kind of go through that box, then the decision is made, okay, should this patient be intubated, or can they actually get a trial of non-invasive ventilation? Okay, and then at the bottom is, well, what are they looking for to see if the patient is improving or not? Okay, so it's a little algorithm that kind of a helpful guide. I usually tell them when they come to the simulation lab, take a picture of it and just keep it in your phone just so they can always refer. So now we're going to shift a little bit to invasive ventilation, okay? We'll start with airways again. So with invasive ventilation, earlier I had stated that we provide that either oral or nasal endotracheal tube. So you have your endotracheal tube here, okay? You have the cuff at the end, which is going to seal off the trachea. And then this diagram up here is the patient who is orally intubated. And then at the bottom is a patient who is nasally intubated. So why is this cuff so important? Well, if you look at this top diagram, remember I said it's to seal off the trachea. We need to have enough pressure in that cuff, which is managed by the respiratory therapist here, to make sure that there's just enough to seal off the trachea. Now, we want to make sure we have it at an accurate pressure because we don't want to cause microaspirations. And then we also want to be able to properly ventilate the patient. But if it's inflated too much, which we sometimes do get, especially patients coming from another facility, it will start to cause tracheal damage and lead to tracheomalacia. So what we do is we have a device called a cufflator that actually accurately measures the pressure that's within the cuff. And we like that number to be anywhere from 20 to 30. I always say my magic number is 25, just right there in between, but we use that device and we measure it daily. And then you have your tracheostomy tube. So when a kit of tracheostomy tube kit is opened, there's three parts of it. You have the actual tracheostomy tube with the cuff attached to the end and the pilot balloon. Then you have the inner cannula, and then you have the obturator. The obturator is what we always keep at the bedside just in case of emergency. The inner cannula should always be in place because that's how we not only connect them to the ventilator, but also if this trach tube becomes clogged for whatever reason, it becomes difficult to actually clean it out. So with the inner cannula in place, if it gets clogged, we can always take it out and replace it. The tracheostomy tubes that we use here are disposable. So the inner cannula, we just change it and put a new one in. There's no need to clean it, not like how we used to some years ago. Now they make it so easy for us to take it out and just place a new one back in. Okay, so now let's just go touch on the indications for invasive mechanical ventilation. Apnea, impending respiratory arrest, COPD exacerbation, acute ventilatory failure, acute hypoxemic respiratory failure, or someone who's unable to maintain or protect their airway or manage their secretions. So now, once a decision is made to place the patient on mechanical ventilation, there are two types of support. And usually, right after intubation, they are placed on a full support mode. This is the time to allow the patient to rest. So we're commonly using a ventilator mode that gives a set volume or pressure whenever a breath is actually delivered. We can do it two ways. We can do volume ventilation. We can do pressure ventilation. The difference between the two is volume is where the operator will set the volume for delivery to the patient. And if we do set it on a pressure ventilation, that's when the operator sets the pressure instead. Now, depending on which one you choose, if you choose volume, the pressure will vary. But if you choose pressure, the volume will vary. Now, the most important thing in this mode is that the patient doesn't have to acquire any work of breathing at all. So this is when your patient can be fully sedated. They can be paralyzed. We are basically controlling them. Okay, and on our Draeger vents here, it will be classified as assist control. Okay, so we pretty much use this acronym right here, AC. And if we're in volume ventilation, it will look like VC AC. So it's volume control, assist control. If it's pressure, it's PC, AC, pressure control, assist control. Now, what if now patient has been vented maybe a day or two and the decision is made, okay, let's start to wake this patient up. This is when we provide partial ventilatory support. That now the patient is required to assume some work of breathing to maintain effective alveolar ventilation. And this can also be set as volume or pressure. Now, within those support modes, there are two types of breath delivery. We'll start off with the mandatory breath. And that's when the ventilator delivers the same breath type with every cycle, regardless if the breath is triggered by the patient or the ventilator. So that ventilator controls the timing or tidal volume. And basically what I mean, just to expand a little bit, when we set a rate of 12 breaths per minute, that patient will always get 12 breaths per minute. But however, we sometimes come to the ventilator and we see a total respiratory rate of say 20. And those additional breaths above the 12 is what the patient is triggering. It's not considered spontaneous breathing yet because we have them in a full support mode. But that's when the patient is triggering. It's almost like I'm asking the ventilator for another breath, but the ventilator will still control how much tidal volume they get for that breath and how much pressure. And then the second type of breath delivery will be spontaneous breath. So that's when the ventilator requires every breath to be triggered and cycled by the patient. And the patient will control the timing and the tidal volume. The only thing that we do is that we'll assist the patient's breathing by applying pressure to the airway during the inspiratory phase just to unload the inspiratory muscles. And that's usually by means of what we call pressure support. Okay, so that ends my presentation. And now we're going to hand it off.
Questions? Serios, adică ce
So we're going to hand it off to Dr. Lopez, who is the head of the critical care team. He's the chief of pulmonary medicine, director of critical care medicine, associate director of Department of Medicine, and associate professor of medicine for the Icahn School of Medicine. So welcome, Dr. Lopez.
Thank you, Camille. That's too kind. And thank you, everybody. And thank you for having me here. I'm not going to lie, when Theo told us about the opportunity to share some information with you, I was extremely excited. And, you know, I'm going to quote one of the people that's going to follow me, Dr. Rahman, We are students for life, so learning is always a two-way street. That's one of my quotes I tell the residents. Sharing of information is key in medicine and in life. So with that, I'll try to speak to you a little bit about ventilator settings. And before we do that, we need to get into a few definitions. What is ventilation? Ventilation is nothing more than the interchange of oxygen and carbon dioxide. Ventilation for our purposes is the removal of carbon dioxide in the patient, where oxygenation is the provision of oxygen to the alveoli, where you can then extract and get into the circulation. Compliance, it's important to understand compliance. Compliance is nothing more than the change in volume over the change in pressure. Now, what does that mean? Well, that simply means that for a given volume, you will have a given pressure. And what determines that pressure is the patient's interstitial tissue, the elastance, the resistance, and the chest wall. So people that are larger would have a lower compliance. Those that have COPD would have a higher compliance because they have less tissue, right? PEEP. PEEP is the pressure that is left at end exhalation on a respiratory cycle. Tidal volume, as we know, would be the volume delivered to the patient during a mechanical breath. FiO2, fraction of inspired oxygen, which is bled into the flow, which is the rate at which the gas is delivered to the patient. The flow is measured in liters per minute. Usually 60 liters per minute would be the usual amount. Now, rate, usually we denote it by an F, rate or frequency, and a trigger. Now, mechanical ventilators have 3 triggers. That would be time, pressure, or flow. Right? Time is the rate you set. Pressure, usually most ventilators are set to -2 centimeters of water. So if you add 5 centimeters of PEEP, then you have to do -5 plus -2 gives you a -7 to trigger a breath. And then flow, usually 2 liters per minute would trigger a breath. This is important to note in patients with obstructive lung disease and some degree of auto PEEP, as they may not be able to generate that -7. So you can switch to a flow trigger. And then a ventilator. What is a ventilator? A ventilator is nothing more than a pump. A pump is a machine. A machine does what a machine is designed to do. Ventilators blow air. The first ventilators known, all they did was just blow. And you would tell them blow for X number of times per minute at this rate with this much oxygen. And that was it. Now, how do we get there? Well, I'm going to come back to that slide in just a second, but how do we get there? You know, normal physiology for breathing is a negative pressure system. And if you look at the iron lung, this was the first mechanical ventilator that was developed. This was developed in response to the polio epidemic that was rampant in the world in the early 1900s. Around 1950 or so was when there was an epidemic in, I think, Copenhagen. That's where they started to do invasive mechanical ventilation. Now you can see that these ventilators are not very efficient. And, you know, Theo and I were looking at these pictures one day and we're looking, hey man, that looks like a can of beer, but there's no beer, so it can't be fun. And just kidding. But if you look at it, look how the nurse is accessing the patient through little portals. There's no mobility, so you have muscle loss. There's no way to clean them, so it's disgusting, really. I mean, it's not any way you can live this way. There's no interaction. So obviously not an efficient way for people to live. So let's come back to here. What is the normal breathing? Well, the normal breathing is a negative pressure system. We have a negative pressure between our pleura, and then we have all the elastance of the lungs and the chest wall pulling down. When we initiate a breath, our intercostals open the chest wall and depress the diaphragm. This causes a negative pressure at the alveolar level, pulling in gas. Now, what does this do? This negative pressure exerts pressure on the heart. And as the heart receives this negative pressure, it's a sucking mechanism to help with preload. And this is the way we're designed. This is God's design. We are the best computer. Now, when we change this around, it's analogous to when you have a hybrid car. You're going from gasoline to electric. When you give positive pressure ventilation, and remember that polio epidemic I was mentioning, at that time, they didn't have enough ventilators, so they started doing tracheotomies and having medical students bag patients. At one point, they had almost 150 or so odd patients being bagged, and they couldn't keep it up logistically, which is what led to the development of the mechanical ventilator. So today's mechanical ventilator is usually positive pressure system. Now, when you give positive pressure into the respiratory system, you're going to have an increase in alveolar pressure, which would be transmitted inside the chest and cause an increase in right atrial pressure, which would cause what? A decreased venous return. So you're going to impact the cardiopulmonary relationship, and you have to be cognizant of this. Now, with an increased preload, you're then going to have, a decreased preload, you're going to have then a decreased preload for the LV side, for the left side of the heart. And if you have a low SVR, for example, in sepsis, this can be very, very dangerous, and patients can have hemodynamic collapse. So it's important to be aware of this. However, if you understand the relationships, where would this be really beneficial? Well, if you have high pulmonary pressures or high filling pressures, such as pulmonary edema, at which point you would decrease the RA preload with positive pressure and add pressure to the left side as an LV assist device, and it could be very helpful. Now, as I mentioned, compliance is the change in, actually this is backwards, is a change in volume divided by the change in pressure. We have to be aware of what our patients' compliance is and what our goals are when we decide which settings to use. Now, an important part of respiratory mechanics is your peak airway pressure and your plateau, which is how we can really look at compliance. Peak airway pressure is your dynamic compliance, and it takes into account airway resistance, whereas the plateau is just static pressure. And this is a more true representation of the alveolar pressure, right? Now, when we look at the alveoli, if you look at one alone, it's very linear. It seems simple. But truth be told, the image on the left is one. When you look at four, now you have flow going through 4 alveoli, and it has to distribute, right? And if you look at the third panel on C, you have 45 alveoli. It's just one alveolar unit, and the flow has to distribute through each. If you notice, the amount of flow needed to fill all of those increases incrementally. Now, if you have a pneumonia on one side, you're going to have, inflammation, pus, fluid, and you're going to have less alveolar units open. If that happens, well, pressure will go to the point of least resistance. So the neat effect would be one part of the lung is not open, the other part of the lung is overdistended. And how does this impact our gas exchange? Well, if the alveoli are too overdistended, it can compress the capillaries and the venules and impair and cause VQ mismatch. So it's important to keep this in mind when we move forward. Now, if we look at our pressure volume relationship and what we call the hysterexis curve, let me see if I can get this to work. Well, I don't see the same button. Oh, yeah, here we go. Okay, sorry, here it is. All right. So if we look down here, you have what we call the lower inflection point. I'm using the mouse. Yeah, I'm using the mouse. Thank you. The lower inflection point. And here at the top of the curve, we see the upper inflection point. So when we're at the upper inflection point, it's similar to being overinflated like this. And you're going to have a lot of pressure change with very little volume change. When we're down here at the lower inflection point or below it, you're going to be over here with a collapsed alveoli. And it takes a lot of pressure with very little volume change. All right. Now, ideally, what you want to do is ventilate between these 2 points, which would be your lower and upper inflection points. This is the sweet spot. This is where you have the most compliance. And if you can keep the patient in this range, then you're going to have good recruitment, 1. 2, you're going to have better VQ matching and less collapse. The more you let the alveoli collapse, you lead the way into atelecta trauma. If you overdistend, you can have barotrauma or volume trauma, as they call. So it's important to keep that in mind. Okay, the wrong way. Hold on. Am I going the wrong way? Okay, here we go. Oh, I am going the wrong way. Sorry. Where is it? Okay. Yeah, so this is where I was. We did this slide. So what are the indications and the contraindications for mechanical ventilation? Well, they're quite simple, quite straightforward. We see them every day in critical care. Acute respiratory failure of any cause, be that pneumonia, sepsis, aspiration, altered mental status from a stroke, drug overdose, for example, trauma, concussions, respiratory distress that failed non-invasive ventilation. Important. When we use non-invasive ventilation, you're going to give it as a trial. And within an hour or two, if they're not better, they really should be intubated, because the literature shows that if you don't intubate them, they're going to do a lot worse if you let them continue to fail on non-invasive. Airway protection for massive hemoptysis, severe angioedema, airway burns if you're in a fire, or even caustic congestion for that matter, cardiac arrest, and of course, shock, septic shock, right? So it's always airway, breathing, circulation, right? Okay. Now, how do we do that? Well, you need to prepare, right? So you can't just walk in and have everything ready. The first thing is, remember, always ventilate the patient. While you're ventilating the patient, coordinate with nursing and respiratory therapy. Why? Remember what I told you about the cardiopulmonary relationship. The patients are prone to hypotension when you place them on positive pressure. Make sure they have an IV. If you don't have an IV, you can't resuscitate. Make sure you have an IV, because if you don't have an IV, you can't sedate. And if you try to intubate somebody that's fighting you, it's going to be very difficult. Respiratory therapy, why? We need assistance with ventilation. We need a ventilator with which to put the patient. We need the equipment with which to confirm placement of the ET tube that Ms. Chin already mentioned. You need an end-tidal CO2 color changer, securing device, and ventilator, of course, right? You can intubate the patient, and that goes beyond the scope of this talk. But then cardiovascular support. Remember, many times we have fluids running because we expect the hypotension. We may even have some pressors running if they're available because we expect the hypotension. It's going to happen. And once you can do that, you're going to be able to secure the patient through the whole process. Once they're intubated, they're going to be fighting the vent. Who likes having something in their mouth all the way in the back, stuck in there and, painful, uncomfortable? You have to give analgo sedation, they call it, right? So we start with analgesia, usually with an opioid, usually fentanyl. Why? Because it has minimal cardiovascular interactions, and it's very short half-life, and it's easily titratable. If that's not enough, then you can add another sedative, such as propofol, dexmedetomidine, or any other sedative of your choice. Usually short-acting would be preferable, and we want to titrate that to a sedation score. Here in Queens, we use the Richmond Agitation and Sedation Scale, or ROS. And then it's very important to confirm placement of the tube. You can't just walk away, because what are the potential problems? It can be an esophageal intubation. It could be a right main intubation. It could be up above the cords, or it could be very high just below the cords, which is even more dangerous, because while you're ventilating, everybody walks away. The moment the patient moves, or you try to move the patient to get them to the ICU, they self-extubate. So you want to make sure it's in proper position. Ways you do that: auscultate 5 points. Make sure there's nothing at the belly. Start at the belly. 1, then 2, 3, 4, 5. Next would be frost in the tube, the end-tidal CO2 monitor, as I mentioned, and an X-ray. Now, it is possible to do this with ultrasound as well, and that's, again, beyond the scope of this talk, but we can use ultrasound to make sure it's not in the esophagus, and we could show that it's at least below the cords with an ultrasound, right? And then disposition of the patient. Where's the patient going, right? We need to make sure that we can take the patient to a place where the care he needs can be provided. And that's usually an ICU, all right? During COVID, we were putting them anywhere because we had nowhere else to put them, but usually it's an ICU, right? So once they're on the ventilator, then what do? The respiratory therapist say, "Doc, what do you want? What settings do you want?" Well, as I mentioned, the ventilator is a machine, and it does what you tell it to do. The very first ventilators pretty much just said, "I'm going to give you 12 breaths a minute at 400 cc's at a flow rate of 60. And if you wanted more, you would be sucking against closed valves, and you'd be fighting the ventilator. And I'll be honest with you, man versus machine, man loses, right? So you're going to have complications such as barotrauma, you're going to have pneumothoraces, and so forth. The other thing that actually evolved over time was the design of the endotracheal tube. In the past, there were small balloons and high pressure, and they just made a seal, because you need a seal to deliver positive pressure. One of the evolutions of the endotracheal tube was using a large volume, low pressure cuff that achieves its seal by contact surface area, right? So once that's there, now you can ventilate the patient. And when we noticed that the initial ventilators were causing a lot of bucking, patients would get sedated heavily, they would get paralyzed. And again, this adds to the morbidity. So as technology advanced, our ventilators developed some AI or some algorithms that they could follow. And this is coming with the development of the microchip, of course. And then you have a ventilator that can now go ahead and give you a breath if you need one, or if you trigger it, right? And we'll talk a little bit about that. But the modes of ventilation are volume cycled or pressure cycled, right? Because the machine's going to deliver a breath. How does it know that the breath is given? Well, either it's going to give you a certain volume, or it's going to give you a certain pressure. Depends what you said. Now, if you choose a volume cycle mode, and for our discussion, volume cycle assist control is the most common mode used 90+% of the time. It is the most common and the easiest to use. Now, when you use a volume cycle mode, volume is constant. You're going to get the same 400 cc's, right? But pressure is variable because pressure would depend on compliance, patient effort, patient and the lung elastance, the chest wall, and so forth. If you choose to use a pressure cycled mode, well, then in that setting, you're going to give flow until a pressure limit is reached. When that pressure limit is reached, it'll stop there. And what you're going to get is a variable tidal volume. So you have independent variables and dependent variables. In volume cycle, your volume is independent and your pressure is dependent. Inversely, in pressure cycle, you have pressure as the independent variable and volume would be dependent, right, on the compliance. Now, when we talk about assist, and you heard Ms. Chin speak about assist control. Well, what is assist? That's how the ventilator knows to give a breath. So if you set it to 12 and you triggered the ventilator, now remember you have 3 triggers, time, flow, or pressure. So time is this rate, the set rate you gave. So if you're going over that rate, now you're going into flow or trigger, flow or pressure triggers. So you generate -7, you're going to get a breath, and that's the assist part. So what's the control? Let's say that all of a sudden you're breathing less than 12 and now your internal rate is 8. Well, guess what? Here's the control part. The vent's going to say, no, you're going to get 12. You're going to get 12 and it's going to give you a breath even if you didn't trigger it, right? So that's the assist and the control. Now I mentioned the triggers already, time, pressure, and flow, so we won't waste time on that. But we'll come over now to the little more definition of this. So when we go to assist control, now assist control can be either volume or pressure, and it's up to the clinician to decide which he wants. And there's different reasons why you would do one versus the other. And one of the most important things, and Theo won't let me lie, patient synchrony. You need to have synchrony. When the breath is given, chest and abdomen rise. When the patient exhales, chest and abdomen drop. If you have this synchrony, you're going to have an uncomfortable patient and inefficient ventilation. So remember, assist control in the volume cycled mode is the most common. It has 4 settings, and we'll go over those in a moment. So what is synchronized intermittent mandatory ventilation? Synchronized intermittent mechanical ventilation evolved from intermittent mechanical ventilation. And intermittent mechanical ventilation was developed mostly as a weaning mode back in the day, where people thought, well, why don't we give them some mechanical breaths and in between let them breathe on their own just to get them ready to exercise them. And what they found is that they actually did worse, because when you're supported and then you go to your spontaneous breath, you have to counteract the resistance of the ventilator tubing, the endotracheal tube, as well as the rest of the resistance of the respiratory system. So the work of breathing is increased. Well, again, algorithms and microchips come in, and then they decided to pair that with pressure support. One of the other problems they found with it was that if you are giving a breath every 10 seconds, for example, and you took a breath right before you're going to get one, the machine didn't know, and it would give you a double breath and stack, which can lead to autopeep. So there's where they developed the chip that made it synchronized. And synchronized means that the machine is now reading your breaths. And if you just took a breath, it won't give you the next program breath until the next cycle, right? And it'll let you breathe on your own. When you add the pressure support, it helps counteract the airways resistance and the ventilator circuit resistance, so you can breathe more comfortably. That said, you're now approximating a hybrid of volume and pressure cycled assist control, so hence it's not helpful. It's the same as keeping them on assist control, which is why it's fallen out of favor. We don't really use it at all. Very rarely, people with very bizarre respiratory problems, it may be helpful, especially in an awake patient perhaps that has some muscle weakness, but very uncommonly used. When we go to pressure support ventilation, or PSV, this we usually call CPAP with pressure support. It's usually a bi-level mode, right? And it's analogous to non-invasive bi-level, right? You have a high pressure limit and a low pressure limit. This mode is completely patient triggered. There's no backup rate. The patient's going to take their own breaths, and whatever you give them would generate a pressure limit, and that pressure limit, depending on their compliance, would give you a tidal volume. You adjust the pressure to the minute ventilation you want to achieve, right? Now, with our vents, they're very modern. We can actually tell the ventilator, we want to match this minute ventilation or this tidal volume, and the ventilator would automatically adjust your pressure support to meet that goal. So it's very smart, and it could do that. Some studies have shown that it actually shortens the time of weaning, all right? Now, the last mode, and this is a controversial mode, airway pressure release ventilation. Airway pressure release ventilation, as it sounds, is airway pressure is generated and held, and then it's momentarily released, and then it comes back again. So it's almost a constant positive airway pressure. You have the patient at their TLC and you hold it there. They can breathe in between, and the valves in there maintain the pressure but allow them to generate breaths. The breaths are generally smaller because they can't exhale well against the pressure, but it's very good for lung recruitment, okay? And it has intermittent releases, which is where you generate the ventilation part or the clearance of the CO2, okay? Now, again, there's certain circumstances where this would be helpful, all right? Now, the settings. What can you set on a ventilator? I mentioned the FiO2, right? FiO2 is the fraction of inspired oxygen in the gas. Now, remember, we're all addicted to oxygen. We all breathe 21% oxygen. There's no way you can't breathe 21% oxygen, right? You would not be happy. So at least 21 you would have on a ventilator would be room air, but you would go from there. When you intubate somebody, the first setting is 100%, and then you bring it down. Exceptions to that, a clinician may decide to go lower if they're intubating for mental status, for example, or for airway protection with normal lungs. You remember the whole issue of the polio people. Well, these are people with intrinsically normal lungs and neuromuscular failure. So they really didn't need oxygen. Those iron lungs didn't have oxygen. They were just breathing room air, right? On a mechanical ventilator, we would start at 100 and then titrate down based on your oxygen saturation and arterial blood gas. You would target an SpO2 of 92 to 95. You know, when we walk through the ICU, if they're up at 50% and 100, you just keep dropping until you hit this range, 92, 94, 95, right? The tidal volume. Now, this is an area of debate. When you look at the tidal volume, most people would use 6 to 8 cc per kilo of predicted body weight. Why is that? Well, if you are obese, your lungs aren't obese. It's the body that's obese. If you're cachectic, your lungs remain the same size. Whether you're obese or you're cachectic or your normal build, your lungs are the same size. So it's predicted body weight, and there's a formula that you can use. I apologize. We're using inches here. It'd probably be centimeters in Europe. But you would then generate 6 to 8 cc's per kilo. Now, there's a study that you can refer to, and it was published in JAMA, I think somewhere around 2018. And it was the PREVENT trial, I believe it was. And in the the PREVENT trial, right? They used intermediate level of tidal volumes, and they went a little higher than this because this was for patients with ARDS. Now, in the PREVENT trial, what they were able to show is that if you did not have ARDS and you use a little bit of higher tidal volume and the patient was comfortable and the airway pressures remained with the plateau less than 30, there was no difference in outcome. So you can use a higher tidal volume for patient comfort. However, usually 6 to 8 would be where most of us would start, and then we adjust based on patient synchrony, patient comfort. If you're using volume cycled. If you're using pressure cycled, then we talk about an inspiratory pressure limit, usually anywhere in the range of 10 to 20, and it can go higher than that, but certainly you don't want it more than 30, right? If you go more than 30, then your plateau will be more than 30, and that's not anywhere we want to be. All right. And again, patient comfort and minute ventilation being met. PEEP, based on the ARGNet trial. I know this trial was published. It's a landmark trial. Everybody, I guess, knows about it, even non-physicians. It was published in 2000 in the New England Journal of Medicine. And this is a trial that looked at low tidal volume, high PEEP ventilation of ARDS patients, specifically ARDS patients. And in this trial, what they were able to show is that there was a mortality benefit, and it was actually ended before it finished because the results were so robust. And what they did was they started at 5 and they would go up for hypoxia and incrementally increase your PEEP while increasing the FiO2 And there's a table that I'll show you, I think is a slide ahead of this, that gives you that whole table of how to do it. The respiratory rate doesn't really matter in an assist control mode other than it being a backup rate. Remember, I told you, if you want to breathe over it, you can breathe as much as you want. So if the patient's breathing 20 per minute and you have it at 12, they're going to be having 20 spontaneous breaths assisted by the ventilator. If they go below the 12, then the ventilator would take over and do controlled breaths. But 10 to 12 is fine. If they're a little bit more acidemic or maybe just a little bit more anxious and they want to breathe a little more, you can take it up to 16. It doesn't really make a difference. The one caveat I would tell you with the respiratory rate, and this is one of my pet peeves. That means these are one of the things that bothers me when I go downstairs sometimes to the emergency room. It's very common in a very emergent situation to use rapid sequence intubation with neuromuscular blockade. If you're intubating somebody that has lactic acidosis or they have, say, kidney failure with severe metabolic acidosis, well, these patients are breathing 40 and 50 times a minute. And that's the reason, one of the reasons you're intubating them. If you take away that respiratory drive with a neuromuscular blockade, well, the compensation of that acidosis is immediately reversed. And that patient's pH is going to plummet and they're going to have immediate cardiorespiratory deterioration right before your eyes, and they'll code right in front of you. So when you put them on a ventilator, you have to crank the respiratory rate to try to match their minute ventilation. So if they're breathing 20, 30, 40 times a minute, take the respiratory rate to 20, 30, 35. You usually wouldn't go more than 35 times a minute on a ventilator. And the reason for that is that you can actually generate auto peak from this, right? Because if you don't give enough time for the patient to exhale, then you're going to have residuals of the prior breath trapped in the lung while you're giving the next breath. And that could lead to very bad outcomes as well, which we could talk about. The flow rate, usually we do not touch it much unless there's problems with an obstructed patient with COPD exacerbation or asthma. Usually it's 16 liters per minute or above, or an inspiratory time of 1 second. Depending which ventilator you have, it'll give you an inspiratory time or a flow rate. When we go to the bedside and we see they're asthmatic and they usually have an IDE ratio of 1 to 10 or 1 to 12, and the ventilator is set to 1 to 3, well, they're going to be auto-peeping. So you need to decrease the inspiratory time. Now, how the flow is delivered is also variable. You can either give a decelerating ramp, an accelerating ramp, a sine delivery, or a square delivery. I personally prefer the square delivery, which is constant delivery. Some people think it may be a little more uncomfortable, but it gives you a very predictable inspiratory time. And this way you can measure and calibrate your IDE ratio very easily. Once the patient's intubated and you set your FiO2, your tidal volume or your pressure, your PEEP, your rate, your flow, you don't just walk away. You have to observe the patient. You have to make sure they're synchronous. And you need an ABG, or at the bare minimum, I would say oxygen saturation, but you do need an ABG to assess the acid base if that's the reason they're being intubated. And then you do ongoing adjustments. If you're going to be doing a lot of adjustments, you may want to consider an arterial line. And you also want to look at your peak airway pressure and your plateau. And this is to ensure you're not over distending. And we'll talk a little bit more about that down on the next slides. This is the ARDSNet protocol. And this was published in, as I said, in the JAMA in 2000. And you could see how they have a low strategy and a higher strategy. There was a subsequent study, I believe, that showed that the higher was preferable than the lower strategy. When would you use the lower strategy? Well, if you have people prone to barotrauma, they have a lot of blebs or things like that, it gives you the option. All right. Now, as I mentioned, assist control, what are the benefits of assist control? It provides assistance on all breaths. So the patient has rest of the pulmonary system. All right. The ventilator will initiate the breaths if it's below the set rate. It can be both pressure or volume. All the breaths are identical, as I mentioned, and all the breaths are identical in volume cycle, I'm sorry. And all the breaths have the same pressure in volume cycle, in pressure cycle, sorry. The settings, normally 4 to 8. 4 is the minimum that the ARDSNet protocol will give you. And you would start at 6. And if you're not meeting your goals, you can drop to 4. You can go to 8, or you can take it up to 10 even, depending on the indication. If it's not ARDS, you can go to the higher rates. I mentioned the respiratory rate, the FiO2, the PEEP, and the cycling mode. And now, when we look at the airway pressure in the plateau, another measure to look at is the driving pressure. And the driving pressure is a more true representation of the transpulmonary pressure. And what you want to do there is take the PEEP and subtract it from the plateau. And you want to have that number be as close to 15 as possible. And that would prevent overdistension and barotrauma. This is a flow of flow waveform. And what we're seeing here is that this is in a volume cycled mode. In CMV, there's no negative deflection before the breath. In assist control, there's a negative deflection and the breath is given. They're both identical. Here you see all the breaths are identical. To note here, there's an inspiratory pause, and you can see that there. And this is the plateau pressure that's being generated there. Okay. In a pressure cycled mode, you're going to see that the pressure is identical in all of them. All right. And here the volume is because the compliance didn't change. Okay. Now, synchronized intermittent mandatory ventilation, as I mentioned, it adjusts to the patient's efforts. Not all the breaths are supported unless you add pressure support to this. Similar settings to assist control, so I'm not going to waste time on that. And this is what the waveform looks like. This is a mechanical breath. You can see it's identical and identical. And here we can see that these are spontaneous breaths, right? And you can see where it's triggered, the negative deflection before the breaths, right? Okay. Here you see how it lines up the patient's effort with a control mode. Here the patient's totally passive, so his breaths are all aligned. Here, the patient is triggering, you can see the negative deflection, and you can see that they're all aligned. In an IMV mode, remember I mentioned IMV is not synchronized. So here you see the patient got a breath while he was taking a breath, right? And here you see it happened again. And here you see he took a breath and he got a breath right immediately after, before he barely finished exhaling, right? So that led to SIMB, where you see it's perfectly synchronized and you don't have any triggered breaths without a mechanical breath, right? That's important to note that we don't use IMB, just SIMB, and we don't use SIMB anymore anyway. Now, pressure support ventilation, you must understand that this is totally patient triggered. This is very useful, in, let's say, in patients that are intubated for airway protection. They had angioedema and they're awake, their lungs are normal. You can just put them on CPAP with pressure support and let them breathe on their own. They can increase or decrease their minute ventilation as they need to. It's often used, or most often used, for weaning. When we want to wean somebody, we'll wake them up, sedation vacation, and put them on CPAP with pressure support and sequentially bring down the pressure support until we can extubate them if their parameters are adequate. Now, it does not deliver any set tidal volume or respiratory rate. It's totally patient dependent, all right? That said, it's not for patients that are having issues with mental status, hemodynamic instability, or cardiac arrest. If you leave them on too long and the patient starts to fatigue, remember, minute ventilation is your respiratory rate times your tidal volume. So if your tidal volume goes down, your respiratory rate must come up. If your respiratory rate comes up, you're going to have increased work of breathing. If you have increased work of breathing, well, what's that going to generate? More oxygen consumption and even lactate. So it can lead to CO2 retention, acidosis, and work of breathing. Right? The settings, usually pressure support is 5 to 15, PEEP is usually at 5. FiO2, we would titrate down to the lowest possible. That maintains a SAT 9295. As I mentioned before, we can add a volume target to it, and the machine can do some auto titrating for us. Now, airway pressure release ventilation is a very interesting mode and is analogous to inverse ratio ventilation. And I'll show you on the next slide how that looks. Here we set 4 parameters: pressure high, pressure low, time low. The upper limit of, or the pressure high, is usually set to the plateau pressure. So you want the patient at a full breath, and time high depends how much time you want to allow for gas interchange. The pressure low usually goes to 0 to let them exhale, and T low is usually set to stop when the expiratory flow hits about 50%. So usually you're going to have about 80 to 95% of the cycle in T high. You're going to have 5 to 20% in the T low time. Now, this is what it looks like. And what you're looking at, inverse ratio, right? They're at TLC the whole time, and then they release, and then they take another breath and they hold it. It's very good for airway recruitment. But you must keep in mind certain things. Remember what I told you about positive pressure in the chest. If you have a patient with pulmonary hypertension or an intracardiac shunt, this may be very detrimental to that patient. So you have to be very cognizant of that. If you look here at the exhalation flow diagram, you see that 2/3 of it, it goes back to inhalation. And if you notice, they're breathing spontaneously throughout the T high zone. So they can breathe independently, they can be more awake, they can be a little more comfortable, and they'll be recruiting. So when is it used? It's used usually in ARDS that's difficult to oxygenate. And keep in mind, if you're at TLC the whole time, the time for gas exchange at the alveolar level is increased. So if you have more time for gas exchange, it's good, right? You can use it in acute lung injury and also in post post-operative atelectasis, because giving the gentle pressure at the plateau level, you're going to be able to open up and recruit a lot more lungs. Now, when we look at the ART trial, it was the airway recruitment trial for ARDS. This was published in JAMA in about 2017. And it's funny because it was published right after the ATS statement on the mechanical settings for ARDS. And the ATS published their article in March, and their recommendation on recruitment maneuvers for atelectasis was that it was good and you should do it. However, they made a caveat. Several randomized controlled trials are going to be published, and they may guide this statement further. And so they published in March. In September, they published the ART trial. And the ART trial found that recruitment didn't help and it was actually harmful. So we don't do recruitment maneuvers anymore. When I was a young resident, we had size on our Puritan Bennett ventilators, the old workhorse. And they would give you a double breath, a few times every couple of hours to try to recruit lung. During the COVID epidemic and before that, we were doing high PEEP recruitment maneuvers, the Brazilian technique, for example, where you would take the patient to PEEP of 40 for 45 seconds and then release. It does recruit. It recruits very well. However, once you release the pressure, they de-recruit right away. So it was not really helpful. And that was shown in the ART trial that those patients actually did worse. So postoperative atelectasis is an indication for airway pressure release ventilation. And the advantage is, well, it gives you good control over the plateau pressure. So you're not going to have barotrauma per se. The patient can breathe independently. They can be less sedated. They can be more awake. It enhances recruitment. And, there's a lot of good stuff. But as I mentioned previously, it can be very bad in patients with pulmonary hypertension. And there's no data to support this in neuromuscular disease or obstructive patients. And if you have a very heavily sedated patient, it's not really good either. All right. Troubleshooting. Now the patient's on the ventilator and the nurse calls you, patient's hypoxic. Well, what do you do? Well, the hypoxia is going to be dependent on your FiO2 and your PEEP, right? What does that mean? Your mean arterial pressure mean airway pressure needs to increase for you to improve oxygenation. If they're hypercapnic, well, this is dependent on their tidal volume and or rate. And if you are in APRV, T low and P low, right? Because there's where you're going to have the ventilation. Now, remember I mentioned peak airway pressure and plateau and the importance of these. Well, if they call you to the ventilator and they say it's alarming and the pressures are elevated and you do a plateau reading and you find that you have an elevated peak airway pressure with a normal plateau, and that means a difference between them of more than 10 centimeters of water pressure, right? It's a big difference. Well, what does that mean? That equals an issue with resistance. Resistance would be either bronchospasm, mucus plugging, or kink tube, right? Which means you need a lot of pressure to beat the obstruction, but once the obstruction is beat, the lung itself is okay, and it distributes normally. So you need to suction, give bronchodilators, or just review your tubes. A lot of times the tubes kink at the mouth where the ET tube holder is, it just bends, right? And sometimes they leave the catheter stays in, the suction catheter, and causes an obstruction as well. If you do your readings and you see that your peak airway pressure is elevated and your plateau is elevated and their difference is less than 10, now we're talking about a problem with compliance. And if you have a compliance issue, well, what can cause that? Pneumothorax, pulmonary edema, atelectasis, ARDS, right? Pulmonary vascular congestion. To this, you would have to address the underlying cause. If it's a pneumothorax, chest tube, if you're seeing you're having a lot of volume issues, either some diuretics or increase your PEEP. If it's ARDS, increase your PEEP by the ARDSNet protocol, all right? There's a little schematic of ventilation and oxygenation. And as I mentioned, as you can see here, mean airway pressure is what drives oxygenation, as well as your FiO2, these two variables. And how do you increase mean airway pressure? You can increase it by PEEP or inspiratory pressure or inspiratory time. Ventilation is what controls carbon dioxide. And this is dependent on tidal volume and respiratory rate. Your tidal volume is either increasing the pressure or increasing the volume. Your rate, your set rate, or your spontaneous rate. If they are, say, paralyzed and you unparalyze them, they can breathe over the vent. Okay. With that, I think, let me see. These are my references. I had a summary slide that I had put in there, but it didn't save, so I apologize. But what you need to keep in mind is that the important thing is, one, patient synchrony. Doesn't matter what mode they're in, patients will breathe. There's a few things in life you cannot do. One is you can't stop breathing. I dare you all to try. Hold your breath and try. You can't, right? So the mode that achieves the best ventilator synchrony, be mindful of auto-PEEP. When you give a positive pressure breath, you must allow that I to E ratio to work. If you see that the flow doesn't come back to zero at the end of exhalation, then you're at high risk of auto-PEEPing. And auto-PEEPing is very dangerous because it can have hemodynamic consequences, and it can also have barotrauma consequences, right? And always, 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 when in doubt, there's always somebody to ask. Use your respiratory therapist. This is an evolving field, and I think with advances in artificial intelligence, we're going to have a lot of progress in this field in terms of things available, and even the machine suggesting to you what would be the ideal mode. With that, I open to any questions, and I hope to have answered some of the confusion regarding this topic.
Thank you very much. Thank you.
You have questions? What kind of ventilation is more comfortable for the patient?
Pardon me, can you repeat?
You have a choice for choose one of other type of ventilation. What is the best for? What is the property for the patient? Who is?
Care e cea mai bună complianță a pacientului? Ce preferă pacientul? Adică care e cea
So
mai...
if we have to choose what kind of mode of ventilation for patient comfort, basically. Depends
great
probably
question.
on the etiology of the
Great question. I would say that the 90% of patients that we have on a ventilator would start off on assist control volume cycled. It is a simple mode, and it will meet the patient's requirements, and it would be one of the most comfortable modes for a patient that is in distress requiring support. Assist control volume cycled. That's hands down first choice. You're going to see most patients coming out of the ER. That's what they're on. The only time they would come out on something different is if either one of us is down there, Theo, myself, or one of our other colleagues, that we would do something different based on the patient's problem. One thing I didn't mention, though, I just wanted to add, I mentioned a lot of the reasons for intubation, but I did not mention pulmonary embolism. If you have pulmonary embolism or severe pulmonary hypertension, be very careful with mechanical ventilation because, again, the cardiopulmonary relationship can be altered very unfavorably in these patients, and they can have a hemodynamic collapse. So try at all costs not to intubate for pulmonary embolism, but if you must be aware of these consequences coming and have fluids and pressors ready for them and thrombolytics.
We have another question from the audience, Ricky. It's pressure controlled, volume controlled. Do you have on the new draggers, because I think they will use draggers here, a hybrid type of switching during a respiratory cycle from pressure control to volume control? There, do draggers.
That mode, yes, that mode is SIMV.
Yeah.
Yes, that mode is SIMV. There's not a lot of benefit to using SIMV. So SIMV would give you a mechanical volume cycle mode paired with pressure support. Now, the issue with that is, it was designed as a weaning mode. And what we've learned over the years is that patients will wean when they're ready. When they're ready, doesn't matter what mode they're on, they can come off the ventilator. So yes, that mode does exist. It's called SIMV, but not really used very often anymore. We would go from assist control straight to CPAP with pressure support for weaning. Now, we do have a mode on the Draeger, which is called MMV, which is mandatory minute ventilation, where here you would give it a setting, a target, and it would fluctuate the pressure support as needed to help wean the patient.
Okay. Any other questions, guys?
La indicații, ați văzut că indicațiile și contraindicațiile au fost pe același slide. Vi s-a părut că...
Excellent presentations. Thank you. That's all. We are good for now.
Thank you so much.
Waiting to apply on your simulation program right now. We have a lot of knowledge, a lot of excitement here. So they got all the information. They took notes. So we'll apply it. We'll do the best on our simulation exam. I can assure you right now. We are prepared.
Thank you so much, guys. Leave it with Barry.
Okay.
Yep.
Thank
Dr.
you.
Smith,
Thank
sorry.
you.
Yes, thank you.
Yeah, thank
All right,
you, Dr. Lopez, and thank you, Camille Matthew. Excellent presentations. Our next two presenters are on deck. Before that, we're going to take a 5-minute break so you can stand up and stretch. Tutsot Bene. Did I say that right? Tutsot
Yes,
Bene?
it's good.
Okay,
Thank you. It's been that.
Okay. One thing I want to impress is that we're colleagues, even though we're in America and you're in the East, and that this is a collaborative venture. So your input and your questions and your discussion, or if you've had a patient that you want to ask us how we treat over here in the East, in the West, please bring it for discussion. I want to take this time just to thank Camille Matthew. I want to thank Dr. Lopez, and I want to thank, even beforehand, our next two presenters, Dr. Rahman and Dr. Sonna. Dr. Rahman will go over respiratory mechanics and waveforms, and then Dr. Sonna will go over weaning and liberation mechanical ventilation, and then we'll go on into the simulations. So we'll see you again in about 5 minutes.
Thank you very much.
O să clarific, ați înțeles ce a însemnat cu presiunea? Deci când pui o presiune, positive pressure ventilation, în your thorax, aceasta poate cauza some hemodynamic instability. Ați înțeles de ce MP sau pulmonary hypertension, când aplici pulmonary positive pressure, poate să-ți facă probleme?
Da.
De ce?
Pentru că e vorba de atât cu presiunile care scad, care de fapt crește și practic preload-ul să pui într-o poziție și așa după aceea, astfel încât să
Un mecanism, dar în general ce face? La nivel global, când pui pe cineva positive pressure ventilation, când pui positive pressure ventilation, bypass, CPAP, ce face la preload global și la postload la ei? Care sunt efectele de hemodynamics? Reduce preload-ul, reduce afterload-ul, preload-ul și afterload. Ce face positive pressure ventilation? Când pui pe cineva, puneți pe bypass, somnologie. Dacă e în CHF cu somnologie, ce face la preload? Pentru că e indicație și de bypass, CHF. Când cineva vine cu CHF exacerbation, pui...
În momentul în care faci presiune pozitivă, cum trebuie să fie înaltă presiunea? În mod normal, cum este presiunea? Cum ar trebui să fie? La sfârșitul expirului, pentru că rămânul este gol, negativ.
Pentru că asta e pozitiv, it's not physiologic type of ventilation. Iron lungs erau fiziologic în care pui presiune negativă în funcție torac, cum au făcut în Danemarca, ale era, dar nu poți să aplici.
Noi avem în diafragmele presiune negativă, da? Și în plămâni, noi acum introducem prin ventilație mecanică presiune pozitivă. Deci mergem pe ceva ce nu este fiziologic. Tocmai ca să introducem o concentrație mai mare de oxigen, și atunci trebuie să introducem oxigenul cu o presiune suplimentară. În momentul în care tu pui o presiune suplimentară în alveolă, da? Ajunge la nivelul de 0. Pentru că de asta trebuie să pui un PET la final de 5, cu alta începi. Pentru că așa îți asigură un echilibru oarecum al părții mecanice pe care tu o faci. Și atunci vii cu o presiune pe ce? Pe circulație. Nu vii cu presiune pe circulație? Pe circulație pulmonară. Bun. Și acum haideți să ne gândim în spate. Cum merge presiunea aia pe ventriculul drept? Ce se întâmplă cu presiunea aia ventriculul drept, care noi o punem în alveolă? Și ce se întâmplă cu presiunea aia în atriul stâng? Preload și afterload. Hai să ne gândim. Ce va crește?
Asta e global, scade. Când pui presiune global, când îți vine în IVC și în SVC, scade preload. Scade total afterload-ul. Dar tricul care trebuie să-l știți, asta e fiziologic. Efectul de a scade presiunea preload și afterload e bun în CHF, dar pe pulmonary circulation, ce face positive pressure? Efectul e din contră, îți crește. Deci poți să ai o criză de pulmonary hypertension și, în general, dacă ai PI, embolism pulmonar, pulmonary hypertension îți crește. Dacă ai pulmonary hypertension clinic și le dai positive pressure și le dai too much PIP, ei îți colapsează hemodynamics. Deci efectul positive pressure ventilation e diferit pentru circulația sistemică, decrease preload, decrease afterload, și efect total opozit pe circulația pulmonară. care anumite tipuri de pacienți cu pulmonary hypertension, dacă aveți clinici de ale rol sau ceva, hai să nu intubezi, să nu le dai too much feed, le dai numai oxigen. Deci ăsta e efectul fiziologic puțin paradoxal pe pulmonary circulation și colapsează, codează, de asta spune. De asta spunea el, când pui intubație, parcă eu am vorbit tipic de ADS, un subtip de respiratory failure. There's are very broad, COPD, autopip, ce am discutat, întrebarea mai devreme, a fost cu autopipă, DM, prelungește expirația. Deci toate noțiunile fiziologice se aplică acolo. Dar puneți întrebări, că le știți, adică astea sunt de fiziologie și de... Deci o să vină ceilalți doi, o să vină Rahman și Sonna. Deci unul o să vorbească de waveform, o să ne uităm, nu știu, vorbit, compliance, de stress index, genul ăsta. Și a patra va fi, deci iar a vorbit de intubație, îi pui pe BiPAP, pe BiPAP, mechanical ventilation, îi intubezi și când îi extubezi. Asta e. Și cum îi extubezi, să nu îi lasă, nu fii permanent acolo. Deci permanent să vă gândiți cum vor fi extubați, liberation from mechanical.
Deschideți ușa și la ușă deschidem ușa de afară și așa. Aici e de nici nu știu dacă le putem închide. Mai bine deschideți ușa și veți
Problema cu APRB este puternic și el drive-ul de a inspira ce să și nu? Dacă țineți urechile deschise și întrebările care vor fi la simulation o să știți toate. Când compliance, cum o calculezi, COPD, autopilot, toate noțiunile astea care sunt destul de multe băgate acum, dar se vor clarifica, de asta va fi și game-ul la sfârșit în care trebuie să răspund. Să vă puneți pe grupulețe, fiecare grupuleț va avea task-uri. Câte locuri aveți pe an de rezidență? Sunt 5 ani. Câți rezidenți sunteți pe an?
Cred că depinde. Generația noastră a fost generația COVID și am fost 50, 60 de
Dar de ce depinde? 50 pe an?
Da, fac de 10 ani.
18. Hello? Hey, what's up, really? Okay. Nice.
Okay, Romania, we're back. We're going to continue. Hi, we're going to continue the program here with respiratory mechanics and waveforms. It's my distinct pleasure to introduce Dr. Habibur Rahman. He is a senior critical care pulmonary physician, has been at Queens for over 27 years. He brings a lot of knowledge to the table, and it should be a very enjoyable talk. So Dr. Rahman.
Good morning to everybody. Thank you, Gary, for your kind introduction. Actually, I'm going to talk about, as you know, lung mechanics and the waveform analysis. As you know, during mechanical ventilation, the energy is transferred from the ventilator to the patients. And this energy, called mechanical power, which is the product of respiratory rate and the inflation energy of the respiratory system of the lungs during the tidal cycle. It is that inflation energy that inflates the lung and deflates it when it's withdrawn, creates some degree of stress, and the stress is beyond the critical threshold, a degree of strain, which is otherwise called deformation of the tissue structures, and that can potentially affect the lungs, its remodeling and biotrauma, etc., which I will talk a little bit more in details. Now, before I start talking about this mechanical component, the energy component, stress and strain, it's necessary to mention a few very basic foundational concepts. As you recall, when the lung returns to the functional residual capacity, the collapse is prevented by the surfactants, which reduces surface tension between the water molecules at the air fluid interface. As you can see here, as a type 2 pneumocytes producing surfactant, which is a phospholipid dipylmethyl lecithin and choline, and that is packaged in the lamellar body, which is a multi-layered lamellar body stationed right at the cell membrane. And then from there, when it's excreted, it goes into that area where it has a hydrophobic pole and a hydrophilic pole. The hydrophilic pole is looking at the air-water interface and hydrophobic in attachment with the tissue membrane by creating repulsion between the water molecules. Had it not happened, the lung at its low volume would have collapsed and the work of breathing would have been tremendous and unsustainable. So that's a very important thing to remember, as opposed to when the lung is inflated with inflation energy, then the elastic property of the lung kicks in. As the elastic property, they get stressed and you have energy generation there, it wants to come back. And the lung inflation will have to overcome the elastic nature of the lung. If you look here, as main topics is going to focus on the energy transfer and how it affects the lung and how we as respiratory caregivers can manage the system, the machineries in a patient depending on his or her unique nature and custom make the energy transfer in a way so that we minimize damage while at the same time providing adequate ventilation, minimizing dead space, and stabilizing cardiac output. As it turns out, the elastic tissue of the lung is more of an energy conservative in nature. If you stretch this elastic string, it stretches and then of course there's potential energy. And then when you let it go, it returns without any dissipation of energy. So there is no significant energy loss here. On the other hand, you can imagine certain other tissue components within the lung. You can compare them with some kind of paper clips. If you bend the paper clips, depending on the degree of bending and the frequency of bending, at some point it breaks. And this is a kind of energy which is more of a dissipative in nature, and so eventually it is disruptive. And it is that dissipative energy in the lungs, particularly in a patient's lung injury with ARDS, that causes dispersion and as well as heat generations and biotrauma. So we'll be talking a little bit more about it as we go down the road. Just take a look at this hysteresis of a pressure-volume relationship of the graphics. You have the inspiratory part and you have the expiratory part. Shorter the distance between the two, better it is, because in the lung hysteresis, when the two carbs depart from one another, that generally indicates you're having much more dissipative energy and potential damage to the system. In that situation, it's extraordinarily important for the respiratory physician or caregivers to adjust the system so that the damage can be minimized. You notice that during inflation, more energy is necessary, whereas during deflation, for the same level, the same pressure of 15, you have greater volume. Otherwise, you have the same transpulmonary pressure, but the achievement of the volume is very, very different. This is because of incomplete or perfect, perhaps imperfect property of the elastic nature of the lung and the dissipative energy. And as it comes down to the baseline, as a matter of fact, some surfactant molecules that rapidly moves up and down the production center also gets dissipated. So this is a loss of energy in the system, and it does have some biological impact. Why do we need to understand the lung mechanics and the ventilator graphics? In order to minimize the lung injuries, including barotrauma, volutrauma, oxytrauma, atelectrotrauma, and biotrauma, you may be familiar with all these terms. Secondly, to improve gas exchange, to reduce dead space, maintain cardiac output and hemodynamics, and optimize recruitment of the lung without overdistension, and minimize energy transfer from the ventilator to the patient to reduce strain and therefore strain. And certainly, we want to reduce mortality. And of course, during the whole process, our goal is to create a patient ventilator synchrony, because without that synchrony, of course, there's a disruption, increased metabolic demand, and lots of other complications that I'll be talking about down the road. Now, briefly look at this. When energy is transferred, there are different kinds of pressure that is created within the system. First, we apply the PEEP, because PEEP is the most important element of this, because based on optimum PEEP settings, every other setting depends on optimal PEEP. So it is extremely important that we set the PEEP in the right way. I'll be talking a little bit more about it later. But the PEEP creates some kind of strain if the PEEP particularly goes above a certain critical threshold. But that strain is a static strain. Let's remember that the static strain is not as much damaging to the lung as it is due to the dynamic strain of the lung. Okay, for example, during the driving pressure, as you can see, this component is the driving pressure. Here is the PEEP component of the pressure, and here is the resistive component. This resistive component is not terribly important as it affects the actual stretching of the lung. It's a pressure, but it really does not stretch the lung as much, because this pressure is mostly in the mid-sized bronchi where the maximum airway resistance is. So if the PEEP is slightly more than what is necessary, it can cause a little bit of static strain. That is a little bit damaging, but it will equally at the same time reduce the mechanical strain, because when the lung is inflated, you have less dynamic strain, even though you might end up having a little bit of static strain. This is the most important component where you have a driving pressure, is the pressure difference between the plateau pressure and PEEP. And that is the dynamic component of the stress and strain. And we'll spend a lot of time talking about it and show you some evidences how it affects the lung structure and potential outcome. Look at this graphics, couple of things to show. This is a normal graph where you see when the end inspiratory flow has stopped and you hold it for a few seconds and the pressure equilibrates between the upper airway and the lower airway. You get the peak pressure here, which is the maximum pressure during the delivery of the tidal volume. And the plateau pressure is when there is no flow and the pressure is equilibrated throughout the system at the end of inspiration. And this is pretty normal. The difference should be less than 10 centimeters, usually 5 to 7 centimeters. Now look here, and look at this subtle difference between the two. In both cases, you see a significant difference between the peak pressure and the plateau pressure, the peak pressure and the plateau pressure. But as the pressure is rising in the system, this one takes a curvature. That look is very, very different. And this one is almost straight. This is a situation where you have a high flow as a result of very high flow, it creates increased resistance. As you know, flow is equivalent to the increase of resistance. So you create a difference between the peak and plateau. On the other hand, over here, you have a high resistance simply because of increased resistance in the system, such as in asthma. So remember, both increased flow as well as state of the resistance during the airflow in the medium-sized airway, both can increase the peak pressure. So one needs to distinguish between whether or not this is high flow or is because of actual airway resistance. And then finally, you see here, both the peak and plateau pressure is significantly elevated. This is a situation where the lung compliance is actually decreased, and it can be due to various reasons, which I'll be sharing with you, including principal bronchus intubations, consolidations, lung collapse, ARDS, et cetera, et cetera. Now, just a few words about the resistance. Airway resistance, actually the difference between the peak inspiratory pressure minus the plateau pressure divided by the flow, and the resistance increases due to secretions, the mucus plugging and bronchospasm. At the ET tube level, if the tube is small or ET tube is blocked, then certainly the resistance can increase. At the ventilator circuit level, there could be kinking, the clogging, etc. All of them will increase the resistance. Now, how do you recognize resistance in this system? There's increased difference between the peak and plateau, which I showed you. And if you look at the expiratory flow waveform, there's a decreased peak expiratory flow rate. There's increased expiratory time. You'll see scooping out of the appearance of the expiratory limb. You'll see potential for auto PEEP. All of this thing I will actually pictorially demonstrate as I continue on this talk. There are a couple of basic concepts. Let us just review. I'm sure you all are familiar with this. Is lung compliance, total lung and chest wall compliance together, it is tidal volume divided by plateau pressure minus PEEP. But if you have to calculate the only thoracic wall, chest wall compliance, then it is the tidal volume divided by change of esophageal pressure. And if you want to separate out the lung and then measure the compliance, then it's going to be tidal volume divided by plateau pressure minus PEEP minus change of esophageal pressure. This is more of a research situations. Most importantly, what you need to remember as a student of clinical medicine is the top two. This is an important graphics. Look at the left flow volume versus the right. Here you see a minimum hysteresis and have a high compliance because with minimal pressure, lung is being fully, and it is achieving the volume. And again, the return graphics is very close to the inflation graphics, as opposed to ARDS, where you see the hysteresis has increased. The other thing to remember here is that even though this tracing may not be as obvious as it is shown here pictorially, if you see a point where there was no volume recruited, this pressure is building up, but not much volume. And then from this point onward, there's a rise of volume. And then at some point, it flattens out and moves in the opposite direction. In the same direction, but it's a different angle. So this is often called the lower inflection point. I'll be mentioning several ways to adjust the PEEP, but this is one of the age-old facts that to take into consideration, where the PEEP can be brought up to the point close to the inflection point. And when you see the upper inflection point, this means that beyond this point, actually pressure is going up. You're not really recruiting much lungs. So you're generating high pressure, stretching the lung, causing over distensions and potential damage, but not recruiting much volume. So you would like to keep the tidal volume generally below this level, and your PEEP level can be somewhere around this. But again, I'll be discussing more details because this is pretty much gross, but still could be useful. What is an optimal PEEP? It's the lowest sum of collapse and over distension. You settle your PEEP in a place where you minimize the collapse and at the same time minimize the over distension. If you're creating excessive PEEP, that can increase the static strain, which I showed you earlier, but it can potentially decrease the dynamic strain. And generally speaking, above 10 to 12 centimeter water pressure, PEEP is less likely to be beneficial. However, it needs to be individualized. For example, in obese people where the pleural pressure is positive, increased abdominal tension, or ARDS patients, where actually the pleural pressure tends to go up. And because the transpulmonary pressure is actually the plateau pressure minus pleural pressure, which is the actual distending pressure of the lung, it is sometimes necessary to put an esophageal pressure manometry, station that in the esophagus, measure the pressure, and then adjust the PEEP and slowly increase the PEEP until the pleural pressure starts becoming negative at end expiration. That can be a very refined way of adjusting the PEEP. But the point here is that even though 10 to 12 will be okay for most of the people, but eventually the clinician needs to individualize it based on the individual circumstances where the pleural pressure can be increased. PEEP plateau pressure does not reliably reflect the true stress or strain, especially in obese, ARDS patient and patients with intra-abdominal pressure, which I just mentioned earlier, simply because if the pleural pressure is already positive, then plateau pressure, even though will show, let's say 26 or 27 in a patient who has BMI of 40, but his actual lung distension may not be that much. So because of this, sometimes if you want to have a refined calculation, an esophageal pressure manometry can be helpful. Look at these graphics. This is another thing that was published in Chest in 2010. The first one, you see, the pressure is building up and is slowly curving this way. Here, the stress index is less than 1. And this is a situation where you can increase the PEEP. This one is going straight without bending. Here, the stress index is 1. This is supposed to be close to ideal PEEP. Whereas in this case, lung was being recruited as the pressure was building up and then curving upward. This means excessive distension and therefore a strain. Here, the stress index is more than 1. So you would like to adjust the tidal volume and maybe some of the other parameters, sometimes PEEP, so that the curvature returns to something like this. I'm sure you're all familiar with this, the so-called the baby lung concept. When you talk about 6 ml per kilogram tidal volume in acute lung injury patients, this generally is true and apply to most of the situations, but we eventually need to individualize it because everybody, irrespective of ideal body weight, the lung volume actually has changed because of the underlying condition. Look at this lung here. You have both lung is open and you have a compliance of 50. This lung here, this lung is almost closed and you have a little bit of lung left here, the compliance is only 10. Now, can we apply 6 ml per kilogram tidal volume in both the situation? The answer is no. Obviously, the stress and the strain is going to be widely variable and potentially disastrous. The same situation you can see right here, where you see there's almost a significant part of the bilateral lung is collapsed, about 55%. Here is only 0.9% collapse. So again, the 6 ml you may need to go down in this case, provided just allowing some PCO2 to rise and maintain that way, maintaining adequate cardiac output and preventing further lung injuries. Now, driving pressure is a very, very important component for the clinicians to remember. If you look at this, the lung stress and the driving pressure, even though it's slightly scattered along the vector of the driving pressure, but it's mostly around it. Okay, so driving pressure, as I'll be talking more and more about it, it is exceedingly important issue. Generally, you want to keep it below 15 centimeters or so. And driving pressure is the pressure difference between the plateau pressure and the PEEP. Now, this is a very, very important slide. You see here the different component of the mechanical stress, the mechanical power that affects the stress and strain of the lung. The least is the PEEP, which is a static strain. It can, if excessive PEEP can cause the damage of the lung, but not so much. but most of the damage happens if the driving pressure is a high tidal volume. That is going to cause maximum damage. But in that calculation, respiratory rate is also quite close. As I said earlier, the mechanical power is equal to the product of the respiratory rate times the inflation energy during the tidal cycle. So therefore, unnecessary increase in respiratory rate, which means that you have cyclical deformation of the system, creating a stress and a strain and potentially tissue damage. So you want to set the respiratory rate in a way so that you have a reasonable target of PCO2 and minimize the lung injury. Again, if you look at the hysteresis, it mostly falls around this vector, which is the driving pressure. This is show you in a patient where you keep the PEEP the same, but you slowly increase the driving pressure, versus you keep the driving pressure the same, but slowly increase the PEEP. Notice that the hazard ratio here, look at the graphics here, it's relatively flat, versus this one, hazard ratio here is 1.12 versus 1.19. So clearly showing that between the increased PEEP and driving pressure, high driving pressure is potentially much more damaging. And finally, if you look at this, the relative risk here, the most of the damage is from driving pressure. They can have some effect from PEEP, which I showed you earlier. The plateau pressure ideally should be less than 25. Maybe in ARDS patient, obese patient can go up to 30 or 32 or so, but lower the better. Okay, PEEP is 25 is just a number. And respiratory rate also has some significance here. So these are the important components of the mechanical power we must keep in mind and optimize and individualize each and every situations to minimize stress and strain and improve mortality and, hopefully shorten the time of dependence on the mechanical ventilation. I think I'm going to switch gear now, but before that, remember a target tidal volume based on ideal body weight is good on average to most of the patient, but must be individualized. And it can be potentially dangerous if we don't do that in many circumstances, as I showed you earlier. And change of pressure and the respiratory rate together are equivalent to the mechanical power, which I showed you earlier. Now we're going to switch gear now to go over some ventilator graphics. What is a patient ventilator synchrony? The ventilator should start inspiration at the time of onset of the patient inspiration. It should match. The flow provided by the ventilator should meet the flow demand of the patients. Otherwise, you have flow starvations. And the ventilator inspiratory time should match the patient inspiratory time. Otherwise, the neural inspiration should be at the same time as a mechanical inspiration. Those two matching has to be there. If these things do not match, then you create some kind of dyssynchrony. And we'll be talking more and more about it. Now, the type of dyssynchrony are the three major categories. You have a trigger dyssynchrony that can be ineffective triggering, auto triggering, double triggering, delayed triggering, etc. And float asymmetry or asynchrony, where you have, usually it is, flow starvations. Sometimes you can have problem with excessive flow. And then finally, cycle dyssynchrony, where you have a delayed cycling, where the patient is trying to exhale, but machine is continues to give the breath. Or the patient is asking for more breath, but machine is cycling prematurely, but the patient wants an inspirations. So those are some of the situations where you can have a cycle dyssynchrony. Now look at this graphics. This is a pressure assist control decelerating flow. Here you see flow is decelerating, and you have pressure, equal pressure in all of them. So obviously this is a pressure mode, and the flow is very, very smooth. You can see it's coming back to the baseline before the next breath. Now in this situation, in a pressure mode, if you increase the I time progressively beyond a certain point, you will not be able to recruit any more tidal volume. you will only have a shorter and shorter exhalation time. So yes, sometimes you use a greater I time in certain situation, especially in lung injury where the time constant of the different part of the lungs are quite different. But again, if you continue to increase the I time, and for the same reason the patient has altered time constant, you will end up having air trapping. But this is the normal graphics. Similarly, this is another normal graphic. Here you have a decelerating flow, normal, and it's normal. But if you use a square wave here, you will see the peak pressure will be pretty high and the inspiratory time will be shorter. Okay, that's the main difference between square wave versus decelerating ramp wave. Here is a CPAP tracing. As you can see, the volume is changing from breath to breath. Patient is deciding how much volume to get on the same pressure. When you see that, that is very much, consistent with the CPAP ventilation. Sometimes they ask you in the examination, what is the mode of ventilation? And here is the example of the square wave. You see flow increases very rapidly and then sustain until the I time, inspiratory time is finished, and then rapidly drops and the exhalation begins. Excuse me, pressure also rises a little bit more because you have a very rapid flow delivery into the system. So always look at both inspiratory and expiratory flow, both above and below the isoelectric lines to identify any abnormality. Now, if you look at these graphics, you see, look at the height of the expiratory flow. It is very sharp and tall because lung is trying to exhale very, very quickly. Okay, you have a high expiratory flow rate. And if you look at the pressure curve, you see suddenly pressure curve jumps here. Okay, sudden increase in pressure curve. So patient is trying to exhale. So this is basically over distension of the system. And in the over distension of the system, both peak and plateau pressure will be elevated, as opposed to simply patient exhaling without over distension, then of course the plateau pressure will not increase. In this case, you notice that expiratory flow is not coming back to the baseline. There's a little bit of distance here, and that means you have auto PIP in the system. There you see a dynamic accumulation of the auto PIP. You have respiratory rate that each breath, before the next breath, the lung is not completely emptying, and the next breath is adding more air, and the next breath is adding more air, causing increasingly more dynamic auto PIP. And this can be potentially catastrophic in certain situations where the right ventricular output goes down, and you can have a drop in cardiac output or barotrauma, volutrauma, etc. Here is an example where you have the same tidal volume, but you reduce the flow rate at a different level. As you reduce the flow rate, your E time shortens, okay? When your E time shortens, you have less time for exhalation, you end up accumulating auto PIP. So all these factors are very relevant when you're recognizing auto PIP and not to create an auto PIP, that the factors that can affect the volume of the system, the respiratory rate, and the status of the airway resistance of the underlying system. Now there you see the active exhalation here. You see very, rapid flow, high peak flow here. And you can see that over here also. So when you see this, recognize active exhalation. In this case, you will notice that the expiratory flow continues over until the next breath, but does not come back to the baseline, okay? So this is basically a prolonged expiration, usually some kind of airflow obstruction or auto PIP in the system. There you see a flow volume loop. You see here, it's very, very depressed, as if a thumbprinting here, as opposed to this particular waveform, which is relatively more open. And this is before and after the bronchodilator treatment. As the airway resistance goes down from here to here, you can see improvement has happened. So if on a ventilator, you have this loop in place, and then you give a bronchodilator, and you see these graphic changes, you definitely know that the airway resistance has gotten better. Now, what is the physiologic mechanism of auto-PEEP and end expiratory pressure? There are 4 different ways to think about it. You can have a dynamic hyperinflation with intrinsic expiratory flow limitations. You have a dynamic hyperinflation with flow limitation, for example, COPD. You can have a dynamic hyperinflation without intrinsic expiratory flow limitations. For example, the rapid breaths, the high tidal volume, the inspiration is greater than expiration, and end expiratory pause. And you can have added flow resistance here if you have a small endotracheal tube or ventilator receiving some kind of distortion. But you can also have auto-PEEP without dynamic hyperinflation. For example, the recruitment of the expiratory muscles, the abdominal muscles and expiratory muscles. If the muscles are recruited that transfer the pressure to the pleura, the pleural pressure becomes positive. That is also one kind of auto-PEEP. So remember, there's 4 different ways. You have dynamic hyperinflation plus intrinsic expiratory flow limitations. You have dynamic hyperinflation without intrinsic expiratory flow limitations. And you have added flow resistance due to the external devices such as tube, and then due to exhalation muscle contraction. What is the consequence of auto-PEEP? It increases the work of breathing, and it can lead to ineffective triggering, worsen the oxygenation, can drop the cardiac output, barotrauma, hemodynamic consequences. How do you treat the auto-PEEP? There are several steps you can take depending on the individual situations. You can change the ventilator setting to increasing the expiratory time, decrease the respiratory rate, decrease the tidal volume. That might work under certain circumstances. You can reduce the ventilator demand, for example, take care of the anxiety, pain, fever, shivering, acidosis, etc. That will reduce the ventilator demand. Try to reduce the dead space in the system. And sometimes that's not the first intervention, but if necessary, you can give some sedation. And reduce the flow resistance. If a patient of asthma or COPD, then in that case, give bronchodilator treatment, steroid, to reduce the internal caliber, to improve the internal caliber, and therefore flow. And if you need to suction in case there's a lot of secretion in the system, certainly bronchodilator will help. And when all these things are being done, as a temporizing measures, you can apply some external PEEP. And the external PEEP, as a pressure balloon, will try to dilate the airway from within, partially neutralizing the pleural pressure, and therefore can allow reduction of the dynamic auto-PEEP. Now look at this. You have this vibration going on both through the inspiratory and expiratory. This is a normal one, and this is secretion accumulation in the system. Another example, you see this vibration, this secretion accumulation. All you need to do is just suction the airway. Here you are, you see that breath is coming to an end, and then patient takes another breath at this time before the breath completely ends. It's the second breath, and you see more negative pressure here. And then suddenly you see the pressure in the system goes up. You have 2 consecutive flow without any expiration. So this is a double triggering. Another example of double triggering here, as you can see, there's two different flows back to back. And you see here patient triggering again, double triggering. So patient's inspiration in this case continues after the ventilator inspiration and triggers another breath immediately after the inspiration, because patient really asking for more air. And this is also called breathtaking. And generally because of high ventilator demand of the patient, for example, in ARDS, or you could have an inappropriate settings. For example, you have low tidal volume that the patient is not happy with, or you have a short inspiratory time, patient wants the breath for a longer period of time, or it could be cycle threshold abnormalities. So in individual cases, what is exactly the cause of this double triggering, one needs to find out. Now here's an example of ineffective triggering. If you look here, you have a trigger, but there is no tidal breath. Okay, you have another trigger, and there is no tidal breath. You have a similar situation here, trigger, but there is no tidal breath. Why ineffective triggering? Generally, improper sensitivity of the trigger threshold, be it flow or be it pressure trigger, you got to adjust that, see if there's properly done or not. And there could be respiratory muscle fatigue. For example, critical illness, neuropathy, electrolyte imbalance. In those cases, severe muscle disease, myopathy, that can also cause ineffective triggering. Intrinsic PEEP can be very high because if you have a positive pressure at the end of expiration, which is called auto PEEP, as you understand, the poor pressure has to be negative first to neutralize that intrinsic alveolar pressure, the auto PEEP, and then create additional negative pressure to get the flow. So obviously, auto PEEP can potentially lead to ineffective triggering. And if the respiratory drive is decreased, for example, excessive sedation, that can also cause ineffective triggering. If the pH is alkaline, then you have the depression. The patient obviously doesn't need to breathe as much. External nebulizer can create a pressure in the system, and that if it is a pressure trigger, then if the pressure does not come back to the sensitive point, patient is not going to breathe or could have an ineffective triggering. And certainly high tidal volume and high pressure can also decrease the drive. So in a particular patient, what is exactly causing it, that one has to stand by the ventilator and find out and take care of it. Now here is the situation you see. Look at the pressure wave. It is scooped out, okay? And the patient is not getting enough flow, and that is why you can see this distortion of the appearance. Similarly, look at this flow pressure volume. During the inspiratory pressure, you see a scooped out appearance. This is a flow starvation. Patient is demanding more, but the ventilator is not giving as much. Here is also a flow dysynchrony in a pressure wave. As you can see, the pressure wave is going up here, but again, the patient is demanding, so the pressure wave is not going up as much. So the negative pressure is sort of neutralizing this pressure, giving that appearance. So on a different display of graphics, a particular problem can look different. So one has to really get familiar with how it is going to look like in a particular graph. If necessary, you can change the graph and see, look at the multiple graphs to confirm your diagnosis. Now, as I mentioned at the beginning, the flow dysynchrony is because of high ventilatory demand, for example, in acute lung injury in ARDS, low ventilatory settings such as the flow rate, the tidal volume, and the ramp. And you may need to treat certain conditions, fever, acidosis, etc., that demands high flow. If you treat that, then obviously demand will go down and the flow asynchrony can also get better. But immediately, adjusting the flow rate and tidal volume is the first thing to do. And sometimes if it's feasible, if it's not damaging to the lungs, you can increase the tidal volume, you can increase the flow rate, and you can change to pressure control mode with a variable flow so the patient can choose the flow on a pressure control mode. And you really don't want to suppress all these things in normal physiology by simply paralyzing the system with sedation, but in a very rare exceptional situation, when you have exhausted in your diagnosis and management, you may choose to give some sedation, which may reduce the drive and therefore flow demand. This is an example of a cycle dysynchrony. As you can see, patient is still continuing to deliver the breath while the patient is really trying to excel and creating this appearance. So in this case, you really have to change the eye time or change the volume, do it in a way so that it matches with the patient's inspiration and expiratory cycle. And delayed cycling is generally ventilator continuous inspiration when the actual expiration has started, and that's why you see that upward curvature. And the premature cycling is because the patient's inspiratory effort continues while the expiratory phase of the ventilator has begun. So as I said at the beginning, the two has to match, the patient inspiration and the ventilator's inspiration, patient's expiration and the ventilator's expiration, and the trigger, the neural trigger of the patient and the mechanical trigger from the ventilator, all of them has to match. If those things matches, the dysynchrony is more than 90% reduced. Here is an example of delayed cycling. You notice that breath is going on and the patient is trying to exhale, showing the same upward shift. Here is an example of auto triggering. You see, there's a normal breath demanded by the patient, but then this is a breath from the ventilator, but the patient really didn't want it. And this is a situation where the ventilator delivers an assisted breath that was not initiated by the patient. Why does that happen? It can happen because there is circuit leak at the level of the endotracheal tube. You can have bronchopleural fistula or leak anywhere else, or you have a cough leak. So check those things, whether there is any leak in the system or fluid in the circuit sometimes. Sometimes you can have a very hyperdynamic heart causing great degree of oscillation, and that electrical and magnetic impulse can be sensed by the ventilator as a trigger input. And if the trigger threshold is very, very low, then of course it can auto trigger. So when there's auto triggering, you can look at all those possible differential diagnosis and which one matches the individual patient scenario and fix it accordingly. Now, delayed triggering, the trigger threshold is the pressure and flow that must be attained by the patient's breath to trigger the ventilator. And inspirated trigger time is the time from the initiation of the effort to the trigger threshold. Okay, so that the two has to match, as I mentioned at the beginning. How do you manage the delayed triggering? The time gap between the neural and mechanical inspiration is normally should be about 100 milliseconds, can be up to 100 to 200 milliseconds. And if the gap is more than that, then of course you have a trigger dysynchrony. And you have to identify and treat the auto-PIP, because auto-PIP is a cause of, as you noticed, missed trigger. And you can reduce the minute ventilation, for example, increase the IE ratio, okay? And treat fatigue, acid-base abnormalities. The level of sedation can be adjusted. That is how you manage delayed triggering. Now we're going to show you a few examples of ER leak in the system. As you notice, the expiratory flow, inspirative flow does not come all the way to the end. There is a short, and this is the leak. Similarly here, in a pressure time curve, here you see a certain amount of pressure, and then the next one is this, but the PEEP level remains the same. This is a leak in the system. Again, you have a tidal volume here. It's pretty large tidal volume, and this one is small. And you have a time volume curve. And you see this one is smaller than the first one without any other evidence of anything else going on. This is also a leak in the system. If you're looking at a loop, you see during expiration is going all the way, during expiration is not coming back to the baseline, to the isoelectric line. This is also an example of leak. In a flow volume loop, you see it's not coming, it's supposed to end here, but it's ending prematurely there. That is also a leak in the system. Now, what is the overall consequence of the patient ventilator dysynchrony? It increases the work of breathing. It causes altered structural damage, not only to the respiratory muscles, but also to the microstructure of the lung itself. It worsens the respiratory mechanics, for example, auto-PEEP, alters the gas exchange because the auto-triggering and double triggering, et cetera, can interfere with the gas exchange mechanism, increases the need for sedation. The longer duration of mechanical ventilation, it can lead to fatigue, critical care neuromyopathy, leading to difficulty in weaning, and it can confound lung protective ventilation. For example, double breath. We are trying to protect the lung, but the patient is having double triggering. So your overall ventilation, expansion, and stretch of the lung is actually getting out of control. So, and then it can affect the sleep fragmentation, which has a tremendous impact on the lung biology and overall biology and physiology. And finally, patient may be unable to tolerate non-invasive ventilation because of all that patient has gone through. So some of the take-homes here, the ventilator waveform analysis is a very integral and important component in the management of mechanically ventilated patient. we should develop a habit of looking at the right waveform for the given mode that the patient is being ventilated on, and always look at the inspiratory and expiratory components of the flow time waveform, and do not hesitate to change the scale or speed of the waveform so that you can have a better look and better understanding that might aid in your interpretation. Thank you.
Thank you.
Thank you very much. Excellent presentation. Question, please? Very academic lecture, a little bit complicated. We say thank you. Very good material to process for them. I think it was a lot of information. Very good information. They took pictures and they will process it and they will give us feedback. And excellent presentation.
Thank you everybody. Thanks.
I can tell you for sure. Thank you
very much.
Thank you, Dr. Rahman. And that is why we call him the professor. Very good information, very common problems. All the slide sets will be made available to you through Dr. Theo, but a very common problem, and the waveforms are integral to what we do at bedside. So, we've taken you through why we, put on this end, indications for mechanical ventilation, taking you through the modes, we've taken you through the waveform. So now how do we liberate people, which, that's the most important thing when we put someone on mechanical ventilation, is getting them off. I want to introduce Dr. Larry Sonna, one of our critical care intensivists. He comes to us from Johns Hopkins University, where he did his fellowship in pulmonary critical care. Well-read, and he is very much into research here at the hospital. Dr. Larry Sonna.
Well, thank you. With that introduction, I don't know what to say. I'm brighter than I actually am, if you ask Barry. You've had a lot of academic talk today, and my goal is to give you a much more practical, granular, close to the patient type of a talk, basically on how we, our approach in this institution, to talk about how we approach weaning for mechanical ventilation. And the bottom line of this lecture is very simple. When the patient's ready to come off the machine, take them off. Okay, that's it. That's all you're going to need to know in the next 30 minutes. When the patient's ready, take them off. The challenge is, how do we know the patient is ready? And historically, there were elaborate weaning protocols with a whole variety of ventilator modes and different techniques and different approaches. And around 2000, 2005, we recognized that that approach was all good and well, but fundamentally, when people recover physiologically, the ability to resume spontaneous ventilation, you might not need that elaborate stuff, all that elaborate stuff, the weaning modes, the gradual trials, and what have you. And what we moved to instead was simply protocols that were focused on recognizing when a patient is ready to extubate or wean to extubation, and basically getting to extubate and saving all the fancy stuff for the patients who are hard to extubate. So today I'm going to focus on the basic approach that we use here. Let's see, how do I get the next slide here, guys? Oh, there we go. All right, now we use a multidisciplinary protocolized approach here. And I think there are several cardinal features to the way we approach extubation that are illustrative and that may be of value to other institutions as well. So the cardinal features of the way we approach weaning here is it's evidence-based, and we tend to use the ATS guidelines and the recommendations and up to date are pretty good summaries of the evidence base that you could use and that we can use as well. The second cardinal feature here is that our approach is multidisciplinary, meaning it's not just a physician-driven protocol. We actually rely heavily on respiratory therapists, the nurses, our physicians in training, the interns and residents, the attending physicians, and other staff in the ICU to recognize when a patient is ready to extubate and to extubate them. The third thing is it is protocolized, so everybody knows what we're doing. One of the important features of multidisciplinary approaches is having a protocol. So everybody is basically playing off the same set of rules and everybody knows what everybody else is doing and usually why. Okay. So it is protocolized and the protocol is subject to periodic review by the critical care committees. However, one of the downsides of protocol is you can become rigid about it. And in fact, our protocol allows case-by-case tailoring of what we're doing with the patient as clinically indicated. And the last thing for all of this to work well is monitored outcomes. And our chief of respiratory therapy actually monitors our ventilator days, the number of patients we have ventilated, how many self-extubate, how many patients are extubated by the protocol, and what the reintubation rate is. And that monitored outcome is what allows us to feed back to these other aspects of our institutional approach to make sure that our care is as effective as we possibly can make it. All right. The fundamental step, and I like the word liberation rather than mechanical ventilation. Liberation came into liberation became a popular term about 15, 20 years ago when people recognized that all the weaning may have been overdoing it. There are basically 3 steps to liberation from mechanical ventilation. First one is readiness testing. Recognize who's ready for a trial of liberation from mechanical ventilation. The second one is what we traditionally called weaning. Currently, I think the state-of-the-art science is to go as quickly as possible to a spontaneous breathing trial and reserve other techniques for weaning for the patients who are difficult or who are not doing well in the spontaneous breathing trial. And the third thing is a series of checkpoints just before extubation to make sure that the process goes as safely as possible for the patient. All right, now readiness testing is basically used to determine whether a patient is ready to undergo a spontaneous breathing trial that day. And every day on every intubated patient, prior to physician rounds, respiratory therapy will round through our ICU and assess they'll go through a checklist to assess whether or not the patient's ready for a spontaneous breathing trial. And we'll write the outcome of that on the door to the patient's room so that as the team comes by and evaluates the patient, we can take a quick look at whether or not the patient has passed our readiness test.
Da, deci la noi nu depinde de noi. Deci la capul patului când vine seara, respiratory therapy și nurse-le fac weaning prayer absolut la fel. Deci la noi e politica să nu-i sedezi, să nu stai, fii până acolo și vezi de cu seara, tu când vii dimineața, ăsta a făcut bine, asta n-a făcut bine. Hello? Okay, perfect. All right. Thank you. Da, deci știi că era tendința comfortable numb, deveneai așa sedat, stăteai și dormeai. Ei, acum toată lumea te pușează acolo de la nurse, noi avem și respiratory therapist, cum era Camille. Nu, e specifică pe respiratory therapist, care știu fiziologia respiratorie foarte bine, cum era Camille. Deci ea vine acolo și sunt foarte buni, ei intubează, deci ei sunt... Ce fac de asta, deci termină colegiul și pleca un an, deci un fel de sub-inginer, cum am nici mă... Nu mai e respiratory therapy. Ei diluiesc numai cu non-invasive, invasive și sunt de mare ajutor pentru noi. Unii sunt foarte buni, îți explică la ventilator, dacă ai PIB mare, presiunea mare.
Deci sunt un fel de asistente cu studii superioare.
Asistente specializate pe respiratorie, da. Da, asta e de role definition. Și foarte bine antrenat. Deci Camille și profesoare, colegi, explică fiziologie, o tipă foarte isteață. Și mulți dintre ei sunt buni avem mulți din Caribbean. Caribbean au niște trăsături așa, știi, veneau afroamericanii, prima dată rămâneau prin Caribbean, South America și s-au mixuit local și sunt mulți acolo, sunt din toate țările, din migratori și singuri care sunt acolo. dar cred că e din Haiti, mi se pare. Sunt foarte mulți așa, știu.
Și ea ce face de fapt la patul pacientului? Ea face, ok, nu
Ventilatorul
ea se trează ventilatorul și
da,
ea
da. În general trebuie să te întrebe pe tine, dar știi așa de bine că el se tare.
Ok. Și ați mai spus că aveți pe lângă nursele, aveți în articole nursele care fac ce? Facultatea de administrare de medicamente?
Sedație și administrație. Deci asta, ratio de 1:20 la intermediar, chiar mi se pare, sincer, omor pacient. Deci asta funcționează.
La noi medicul are foarte multă treabă de făcut și nu există, pe lângă medic și asistent, nu există persoană practitioner.
Nurse practitioner e mai mare, are și politizarea de asemenea. Deci e un fel de intermediar serviciu medical care îl dai și îi se dă mai multă responsabilitate că și la noi, în criză de medici. Believe it or not, chit că 20% din forța de muncă, americanii au fost așa de deștepți cu eu din toată lumea și pe banii tăi și peste tot. Tu îți dai singur examene, tu îți plătești, tu te duci și și în rezidență te muncesc destul de bine, mă rog, for good reason. Dar spune ei, nu au băgat niciun ban în tine și ei așa și au forța medicală. Și nurse. Au avut policy de au importat din Filipine cele mai bune nurse pe care de Filipine. Erau filipinezele alea, te trăgeau de mână. Dacă era ceva cu pacientul, nu te lăsau să pleci. Vino pe moare. Decât el. Deci nurse practitioner, intermediate care, mai physician assistant și respiratory therapy. Un fel de, și cum erau ingineri și subingineri, cam așa ceva. Deci acolo physician assistant are drept de a pune ordere, de a pune tot, funcționează de sine stătător, practic, independent.
Care este relația medicului cu ei? Este în relație de colaborare directă sau ei sunt subordonați la pacient?
Cam subordonați, dar acum unii și-au făcut și practice singure, deci subordonați, dar dacă practici anumiți ani, îți iei o licență de a practica, da, un permit din asta să poți să practici. Și dacă n-ai forță medicală, ții destul de mult. La nurse, la noi în ICU, de asta spun, e o nurse la 2 pacienți, ai și 1 la 1 și 1 la 2 și intermediate care unit, de asta spun, adică o nurse la 4-5 pacienți, una la 20, că sunt complicați, adică perfuzii, ritmul, respiră, oprește dripul, dă-i dripul, tușește sânge, nu doarme, nu...
Adică aveți foarte mult personal care este între asistentul simplu și medic. Adică aveți foarte mulți pe fiecare pe specialitatea, pe supra-specializarea ei, fiecare asistent în funcție de tipul de secție.
Și aici nu trebuie, deci ai văzut la respiratorii, înveți de la ei foarte mult și sunt foarte buni. Deci știu ventilatoarele, toate funcțiile la ventilatoare. Deci mai întreb pe ei cum îi calculez eu aici, unde pun pauză, știi? Adică știu. Și textbook, așa.
Știam că sunt tot așa, știam că aveți și nurse care sunt specialiste pe ecografie toracică, pe ecografie cardiacă, care sunt practic niște...
Ecotehnici. Extraordinar. Am văzut și
pe la se pare, da?
Dar aici cine e imaginea? Cardiologul? Cine achiziție imaginii ecografice de cardiologul?
Cardiologul face eco, deci...
Da, dar asta o să învățați voi să recunoați.
Nu avem și nici nu se dă încă o să faci.
We are on.
Okay.
Check sound. We see you. Just we can resume.
All right. Yes. How many of these? I'm going to bandwidth on project.
Larry, we are on. I don't know if you hear us. You can resume your lecture.
All right, so just keep going. Yeah, and let me know when you're ready. Can you just see if they can hear you?
Theo, can you hear me?
Yes, we can hear you perfectly.
Give me the thumbs up if you can see me.
I do not see you, but we see your screen and it's crystal clear.
I see the, I see the, you see the abstract.
And we can hear surrounding sound there. So if you speak on the mic, you should be okay.
All right, we're testing again. Can you hear us? Show me a
Yes,
thumbs up if you can
perfect,
hear us.
clear.
Okay.
Hold on, 1 second. I'm not getting audio from that. Oh, you're having, do you want to join with the next one? Weird that the other one is still up. Must be something with our switch.
Care sunt și Camille, lucrează în clipă și le componează, medicul lucrează de regulă dimineața și gărzi și în rest ceilalți sunt pe ture, adică
Deci noi dimineață și băgam și eu gărzi, că sunt extra plătite. Deci financiar e diferență mare în toată lumea. Plătite chiar bine asta pe terapie intensivă. E acoperit 24 de ore din 24, 7 zile pe săptămână. Serviciul de pulmonari după 4-5 cam pleacă toți, dar dacă e vreo urgență, îl transferă la ICU. Deci la noi avantajul și de asta spune bine, ai pulmonari și critical care together. Se întâmplă ție, te acoperi serviciile, de asta e ceva ce nu înțeleg eu aici și mi se pare.
All right, Theo, we have the ability apparently to communicate with you, but we have lost the ability to hear your conference room over here. So what the audiovisual people are suggesting is that we continue the talk while they work on restoring sound. I just need to make sure that you have, I'm going to ask you 2 questions. The first one is, can you see me? Can everyone see the slides? Okay. And can everyone hear me? That's the second question. Okay.
But we do not see you.
All right, so let's go back to where I was. I've never actually I've never had such a presence that I've caused technology to fail before. This is a new experience. It must be the bow tie, right? All right, so when we talk about, in our institution, liberating from mechanical ventilation, it's basically, it's a 3-component process. The first one is readiness testing, which is designed to identify patients who are candidate for a spontaneous breathing trial and liberation from mechanical ventilation. The second part is the spontaneous breathing trial itself, and the third part is a final checklist of readiness for extubation, the process of extubation itself. So let's talk about how these play out in practice. Readiness testing is basically used to determine whether a patient is ready to undergo a spontaneous breathing trial that day. It's done daily on each intubated patient before physician rounds by a respiratory therapist. And what the therapist will do is go in and assess a checklist of clinical characteristics that are important for patients who are to undergo a spontaneous breathing trial and write the results of that assessment on, basically we have what we call a storyboard that's stuck to the door of the patient's room. And what the therapist will do is either screen the patient for spontaneous breathing trial. If the patient passes, they'll check the pass. If the patient fails, they will check fail and describe the reason or the principal reason why the patient is not ready for a weaning trial. This is important because as the team approaches the door, we will have an assessment of what the therapist thought the most important obstacle to extubation would be. This is an example of a patient who failed their weaning trial because PEEP was still a little too high for entry into our spontaneous breathing trial step. Now, these are the criteria that we use for readiness, and we use criteria that are not simply based on what's happening on the mechanical ventilator. The first one is mental state. We need the patient to be awake enough to cooperate with staff, and more importantly, to be able to protect their airway. The second one is we do not allow, with notable exceptions, the continuous infusion of sedatives and narcotics on a patient who is being extubated. So if they're on a Versed drip, it gets stopped. If it's on a propofol drip, it gets stopped. The sole exception to that in terms of continuous drips in our institution is Precedex. We do allow Precedex because it does not tend to interfere with respiratory status the way, say, narcotics and propofol and benzodiazepine drips do. We also do allow a patient to have intermittent bolusing of sedatives and narcotics, but we do not allow continuous drips in patients that we're going to extubate. The second thing is their neuromuscular state. And it sort of stands to reason the patient should not be on a paralytic infusion, but as with all safety protocols, it's a check on the step. Let's put it this way. Pilots who are landing an airplane are fully aware that the landing gear has to be down, but I can assure you that both the pilot and the co-pilot check the switch that shows that the landing gear is down before they land that plane. Same here. Patient should not be in a paralytic infusion before we do a spontaneous breathing trying. Also, we like to see a presence of a suctioning and gag reflex when we assess the patient for extubation. Cardiovascular state. The main goal for this is to make sure the patient is not in shock or compromised from a cardiac point of view in a way that adding an additional strain would be deleterious. So the protocol calls for a mean arterial pressure of 60 or greater. In practice, we tend to use 65, and this is off continuous pressor infusions. A physician can make an exception to the rule. We sometimes do extubate patients on low pressors, but the key has to be the patient is judged by the team as being capable of tolerating the additional load or of losing the support that the ventilator provides. And the therapist will just make a note as to whether the patient's on press or not. The patient cannot be having an evolving myocardial event, so no extubations while people are having a worsening myocardial event. And we prefer that their hemoglobin be stable, that they not be at high risk or in hemorrhagic shock. Again, stands to reason, but again, part of the protocol is to make sure these safety steps are respected. The third thing is to make sure the patient's respiratory state is acceptable on low pressure support, ventilation, PEEP, and FiO2 settings. Now, what the therapist will do if the patient is on assist control is they will switch him to a low PEEP pressure support, either PS5 or PS8, depending on what size endotracheal tube is, and they will look real quickly and see if the patient's apneic. If they are, the trial stops and they go back on the previous settings. They want to see a rapid shallow breathing index, which is, as you know, is the respiratory rate in breaths per minute divided by the tidal volume in liters. We would take the RISB of 105 or less as indicative that they're ready for spontaneous breathing trial. We want to see that they do not have excessively high respiratory rate or minute ventilation, and that they can in fact maintain PaO2 of 60 or greater or an SpO2 of 90% on this very quick screening test for readiness for spontaneous breathing trial. Now, if the patient meets all criteria, then the respiratory therapist will record the findings on the door, either pass, ready to go, or failed, and the reason why, and return the patient to the previous ventilator settings so that the rounding team can then assess the patient and make sure that all the other things that we think are important before extubating have actually happened or are happening. If these two things, once these two things have happened, we then proceed to a spontaneous breathing trial. If, on the other hand, the patient fails their weaning trial, they'll record the findings and return the patient to the previous ventilator settings, at which point, when physician rounds happen, we will review the finding of the respiratory therapists, and this will help guide our interventions for the next 24 hours, basically based on the reason for failure. So, for example, if the patient is apneic, which we define as not taking a breath within 20 seconds of going on pressure support, the two things I ask the team to look at as a starting point is to review the sedative orders and also to check the blood gases to make sure the patient's apnea wasn't because they were being overventilated to, say, a pH of 7.54. All right, just as an example. Now, if the criteria for a spontaneous breathing trial has met and the physician team agrees, again, this is multidisciplinary, and by the way, part of those rounds also takes into account the nursing input. The team assesses the patient and says, okay, let's go ahead and perform a spontaneous breathing trial. We will also inform the nurse that this is going to happen. The patient is ideally awake enough to hear what's going to happen, so we tell them what the next steps are going to be. The head of the bed is raised to 45 degrees, and the ventilator is set to minimal settings. Pressure support 5, PEEP of 5. Again, if the endotracheal tube is small, we will allow pressure support of 8. And we will start a spontaneous breathing trial for 30 to 45 minutes, monitoring the results. And of course, RISB is one of the cardinal ones, as you know. We will also monitor vital signs, end-tidal CO2, and mental status. If the physician team feels it is important, we will also request that a pre-extubation set of ABGs be obtained. And we will, it depends on the clinical status when or not we order this. If the patient does not raise concerns for us, we will go with the saturation. Also, by the way, we monitor as part of the vital signs, we monitor SpO2. If we're satisfied with the patient's status, we may or may not request a blood gas. It's done on a case-by-case basis, depending on what we think the patient needs and where their failure mode might be. All right, now, the failure criteria for our spontaneous breathing trials, first and foremost, is the RSBI, Rapid Shallow Breathing Index, based on the literature of greater than 105. Greater or equal to 105 is indication of failure of the spontaneous breathing trial, and we basically put them back on the settings, address the medical issues, and go the next day. Sustained tachypnea, desaturation, hypercarbia, or derangement of hemodynamics, either by high heart rate or derangement of either blood pressure, either excessively high or excessively low. We will also look at the patient. If the patient shows visible exam signs of excessive anxiety or distress, we will stop the spontaneous breathing trial, and often we have, if it's truly pure anxiety, we often have a discussion about whether the patient otherwise meets criteria to extubate or what have you. Sometimes if it's diaphoresis because they're just dyspneic, that's another story. And then again, if we have unfavorable AVG results, that may also cancel the decision to proceed forward. All right. If they've passed their spontaneous breathing trial, the next step is to do a final review before extubation. And of course, the first and foremost criterion for extubation is, did the patient pass the spontaneous breathing trial? The second question we ask is, does the patient require excessive amounts of suctioning? Our benchmark is less than if they're needing suctioning less than every 2 hours, we would think about whether to continue for another day, treat the cause of the excessive secretions, and try again the next day. We like to see the presence of gag and cough during suctioning. Personally, I'm more interested in cough than gag, but we would like to see a gag reflex. Ideally, the patient is awake enough to protect their airway and follow one-step commands. Our respiratory therapists routinely perform a cuff leak test in which they deflate the cuff and ensure that there is sufficient air passing around the tube. If the patient does not pass the cuff leak test, then the physicians have to make a judgment as to whether or not to give a trial of steroids before attempting an extubation. We review the arterial blood gases, and in our institution, the final decision to extubate rests on a physician order. The physician is required to give the go-ahead we're required to give the green light to go ahead and extubate the patient. And that's sort of the final safety check before we proceed to extubation. All right? Again, if all criteria are met, the patient is extubated, and post-extubation support. Realize that by this time there's been quite a bit of assessment of the patient that morning, right? And so we will make our best guess as to what the best way to support the patient is going to be post-extubation. And will either be some form of supplemental oxygen, either nasal cannula, face mask, or high-flow nasal cannula, or non-invasive ventilation. Again, this also requires an order from the physician, but it'll typically happen as a result of a discussion between the therapists, the physicians, and the nurses as to what the patient is likely to need to support them post-extubation. And so we will often say, let's extubate to BiPAP. If the patient fails the spontaneous breathing trial, then we return to the previous ventilator settings. We review the situation by the physician team, and most commonly we will simply devise our medical plan for the next 24 hours, principally based on in what way the patient happened to fail. Okay, what was it that happened during the spontaneous breathing trial that led to failure? And then we will either try again the next day, or we will try a different, for the patients who are truly difficult to wean, we will consider one of the more different ways of weaning, such as a pressure support wean. Honestly, in 2024, it's seldom that we actually have to go to pressure support weans. Usually the most important thing is to make sure the patient is medically just to give you an idea of, does this work for us? Well, there are 3/4 of outcome data. Again, these outcome data are monitored, as I mentioned, by our respiratory therapy department. So the question is, does the protocol work? And each quarter we have somewhere between about 90 to 100 patients, with ventilator days about 450 to 500, 550. An average ventilator stay of about 5.3 days, 5.2 to 5.3 days. And actually for patients who are extubated by the SBT protocol, the reintubation rate in our institution is really low. This does not account for people who pull out the tube themselves. This is just reintubations based on having failed the weaning protocol within 24 hours. So our reintubation rate, based on our application protocol, is actually quite low. So in summary, multidisciplinary is the way we do it here, and it works for us. And what I would say is that an effective multidisciplinary ventilator liberation process is a bit like the work of a symphony orchestra, in which each musician plays a coordinated part in the production of a beautiful outcome, in this case, liberation from mechanical ventilation. All right, any questions for me?
Okay, so we may not hear you at this moment, but hold those questions for Dr. Sonna. We will have audio back after the break. We're going to take a 5-minute break. In that meantime, I will.
Thank you. Right. Thank you very much. Excellent presentations. Do you hear us? Image got frozen again. Vreau să explic să-și umanizezi ceva ca să mai consumăm.
Dr. Theo?
Okay.
Yeah,
we
we
hear
are
you.
good.
We are good.
5
Okay.
minutes coffee break.
Yeah, 5-minute call. But before that, does anyone have questions for the liberation strategies that we use here for Dr. Sonna?
No, because it's a little bit more complicated. Here, they are still working on multidisciplinary teams that we have it there. So I appreciate more how easy it is to practice for us there than here. Really, that's seeing there with the team, the help we have it from respiratory therapy, from nursing staff, from everybody. That's the bottom line we are having. There are some issues here and they try to fix it. But small steps.
But thank
Yeah,
you for your,
and the important thing is I want to bring up, as Dr. Sonna clearly said, that the physicians work very closely with respiratory therapy. I want to introduce Dr. Oswald Murray. He's the director of respiratory therapy, and just to give just 2 minutes on how the physicians and respiratory therapists integrate on liberating people.
Good morning, everyone, and nice to meet you. So I'm the Director of Respiratory Care. So we have a very robust multidisciplinary approach to ventilator management that Dr. Sonna expressed to you guys here at Queen's Hospital Center. We collect quite a bit of data on what we do. Dr. Sonna just went through just the extubation portion, but what happened is that the data actually demonstrate or show us what we need to improve on, areas we need to work on, and we also share that information with the multidisciplinary team so that each one or each discipline will have the necessary information so that they could make the necessary adjustment on their care plan that would, when sums up, would deliver the desired outcome that we actually want here at Queen's, which is to, from day one, assess patients for weanability. So that starts from day one. And once there's an opportunity, based on the care provided, to extubate that patient, that's what we'll do. So if the data shown by Dr. Sonna shows that we have very low intubation rate, and that's a result of assessing the patients daily for weanability. And once the patient is ready, we extubate the patient as soon as possible. That's the goal. Our rate of extubation or length of stay is at least 5.2, which based on evidence-based practice, that's a very good number in terms of getting patients off the ventilator. Our goal, of course, is to try to get it as low as possible, but based on, of course, it depends on how the patient condition is and the care provided, but our goal is to try to take the first opportunity we have to get that patient off the ventilator as soon as possible. So if you have any questions, I'm willing to answer it, and all the best.
To reemphasize what my colleague here said, you know, one thing that I've often thought is that the best way to limit ventilator-associated complications is to get the patient off the ventilator as soon as possible. So, I mean, we really view a multidisciplinary approach. And the other part of this is to do it safely, having as many different eyes looking at the patient from as many different angles as possible and bringing it all together comprehensively, I think is a really important reason why our protocol succeeds the way that it does. Because we actually do what the therapist tells me actually matters an awful lot to what we do on rounds. What the nurses tell me matters an awful lot on rounds. And having a protocol that coordinates this so that everybody knows their role, everybody knows what's going to happen next, everybody knows what the expectations of the team are, I find incredibly helpful personally as a practitioner. So if you are thinking of moving to a protocolized multidisciplinary approach, let me offer my services, and I'm going to offer you up as well. We're offering our services in any way that we can assist you, because we have found this to be very valuable on our end.
Thank you very much.
I thank you, Dr. Sonna, and Mr. Murray. Thank you very much. All right, so we're going to move forward with the program. Now it's time for us to roll up our sleeves, and in the practice of Kirkpatrick and Phillips' model of learning, we're climbing the ladder to demonstration and practice to simulation. We have fired up our 3G mannequin, and Dr. Theo, during the break, will team you up in groups of 2 or 3, and you'll be practice care teams. We'll give you a scenario, and then you will march through, make the diagnosis. This is virtual. You will be able to ask what are the lung sounds. We'll give you the lung sounds. Any data that you want to make a decision, you'll be able to ask us, and we'll give you the decision. It should be a couple of fun exercises as we go up the ladder. I know there's first years to fifth years here. The clinical scenarios will get more difficult. So we'll see you in 5 minutes, and thanks a lot.
We'll have 6 teams, just let you know. All right?
Oh, okay, sounds good.
This is the nerve-wracking part.
Talking? Yes. Hello? Hello?
Hold on, sorry. Yes, we are ready.
Hello?
But we don't see you.
Oh.
Put it on the big screen. Teams are ready and excited to compete. Hello? Sure. The teams are ready. So there are 16. That's the question that is directly from us. Yeah, wait. I almost see you. Ce an sunteți? Toți același an, nivel de pregătire? Care sunt anii 5, cei mai seniors? Care sunt anul 3, cei mai juniors? Păi aici, tu e singura? Și în rest între anul 1 și 5, nu? Cam așa.
Da. Dar că n-am făcut parte de ventilație.
Bine, asta e friendly, aici nu mai se învățează. Nu e pressure, nu e nimic. Trebuie să învățează relaxare, să-ți mici. Și chiar dacă e foarte multă informație, să știi. Și rezidenții, și felul, și în state, nu le știu pe asta tot așa de bine.
Dar prima dată e foarte grea. Când mergeți să audiați prezentarea, deci o să vi se pare că, mamă, deja mai nominarea se aștept. Și după aceea o să puteți să întrebați și să mergeți la jumătate și când luați o carte și puteți să citiți pe el și aveți deja mai de timp.
Și ce tip de motivație mecanică? Dobii, ce?
Eu aș mai am recomandat Murray. Adică foarte răspătă.
Are și criteriul să vorbesc de asta.
Foarte. Și Teodora s-a dat pe capitolul de la mea la cu așa, și tot poate da toată carta. Vorbim de Facebook? Capitole cu capitole, dar de ce? Nu putem da Teodora în cabinet. Nu luați. Am astăzat un cabinet.
Voi faceți cercetare? Vă tentează să, deci voi ca și rezidenți, tineri physicians, vă faceți portofoliu academic, să știți unde aplicați, unde vă duce viața, aplicați la cadrul în Europa, în Germania, în Franța, vreți la un centru bun, spital de cercetare.
Din păcate, sistemul din România nu permite acest. Eu, dar Alexandru face doctoratul, ea a făcut și mai face doctorat.
Deci, very level, ultimate doctorat, deci ăsta e MD, PhD, Physician Scientist. Bravo. Și unde publici doctorat? Adică e o grămadă de paper-uri, presupun și ar trebui să le ai, că ai muncă bună, publică. Cine are doctorat trebuie publicat.
Am publicat. MDPI, da.
Da, certificați, trimiteți la FMR, la mine. Deci acum că sunt, cât voi mai fi la ei, sunt American Federation of Medical Research. Eu sunt acolo, organizez și congrese și tot, vice president. Și sunt, dacă vi le puneți acolo publicații, aveți un portofoliu de a publicat, un portofoliu ăla vă mișcați mult mai ușor în viață, nu știți unde e în viață. De ce spun că? Deci eu recrutez și rezidenți și atendiți destul de mulți. Ce-mi vin rezidenții care vin din toată lumea, cred că vin cu publicații minim 15-20, care când am început eu nici n-aveam idee ce înseamnă, s-au schimbat așa de multe, a devenit o competiție foarte bună academică, că sunt din ce în ce mai bune. De asta o să șeruie și când asta să studiez din viață. Da, și spuneți ce paper-uri aveți, dacă vreți să le publicați, da? Nu, trebuie să vă spuneți. Okay. Guys, ready.
Hi, once again from New York to Bucharest. How are you doing? Has this been good for you? Has this been good for you all? Thumbs up?
Yes, everybody.
Okay. All right, so now, as I said, climbing the ladder of Kirkpatrick and Phillips, we'll demonstrate everything that we've gone over in the didactics in the last 2 hours. We'll put it into practice. We have our sim space set up. And the first thing we always do is two things. We remind you that this is simulation, that we have a principle called the Las Vegas principle. If anyone has gone to Las Vegas or has been here, we call the Las Vegas principle what goes on in Las Vegas stays in Las Vegas. And so our thought also is that it's assumed that everyone has the same abilities, and we are here to practice. We all make mistakes, but that's the purpose of simulation, right? The purpose of simulation is to practice in a safe space. So answers could be incorrect, correct, we don't care, because in the end of the day, we all learn from each other, right? So the first thing I'm going to do is have Camille Matthew take us on a tour of our sim space and see what equipment is available to you.
Okay, so welcome again. Just want to start off that, even though it is a mannequin, we do try our best to suspend disbelief, so we will be wearing gloves as if it is an actual patient. So just to introduce you to the mannequin, this is SimMan 3G. It's a high fidelity mannequin designed to suspend disbelief and immerse yourself into simulation. So starting from the head down, his pupils actually react to light and can be pinpoint normal or unequal. He can have nasopharyngeal airways, and nasal intubation is also possible. As you can see right now, he is orally intubated and can be used with LMA as well. And oral pharyngeal airways is also possible to be used in addition to that. I can create tongue swelling, the jaw can clench, I can change it to pharyngeal swelling and neck rigidity. Also pulses, he has palpable pulses starting from the carotid to radial to brachial to femoral and pedal pulses. So all of that is possible to feel for.
They can't see the case right now.
Lung sounds can be auscultated anteriorly and posteriorly. So we're not here to trick you. So if you want to assess the breath sounds, just ask, what are the breath sounds of this patient? Especially since we are in a virtual environment, you will have to ask for those breath sounds. This mannequin, just so you know, can actually take defibrillation. It is CPR compatible. And then I'm going to actually turn it over to Dr. Smith, who's going to go over the next part.
Okay, in our sim space, we have everything that we have on the clinical units. We have our Zoll monitor capable of cardioversion, defibrillation, and everything. We have our airway box that has all our intubation equipment in. And this is a live code cart where we carry all of our intubation materials as well as our ACLS, advanced cardiac life support medications. In the bottom, we have our IV tubings and our mainline saline and lactated ringer bags, and in the bottom, if we need to, we have our thoracotomy tray as well.
Okay. So also what's on the crash cart, if you notice, we have a little black device there. That is our cufflator. So if you feel that we need to assess the ET tube cuff, you can always let us know as well. In addition to that, we have an ambu bag here, attached with a mask if you feel you need that for your scenario. The monitor, it will also be placed there with all the vital signs. We have the glide scope here available with all the different size blades. You can see we have the oxygen tank that's powering up the ventilator. And then over here is the Draeger vent that I had mentioned earlier. So this is what's going to be attached to the mannequin as well. So I just want to turn it on really quickly just to orient you to the screen itself. Okay, good view on the ventilator? Okay. So on the ventilator itself, at the bottom is where all the settings are placed, okay? And then on the side here is what the patient is actually returning. That's all your measured parameters. In the middle, you'll have a few waveforms: pressure, flow, and volume. Over on the far left, we have a few different loops. So the first one is our volume pressure loop. The middle one is our flow volume loop. And the last one is your pressure flow loop. Okay, so you may want to assess that depending on what your scenario is. Over here on the side, I can always freeze waveforms. So if you ask for a plateau pressure and we actually do that, we'll freeze it so that you can assess that value in case the value does not come up. Right now, we have the plateau pressure consistently coming up. So if for a reason it doesn't, we can always measure that as well. Coming down, we have the values button that gives us a whole list of measured parameters. So Draeger does a lot and gives a lot of information. So some additional values you may want to assess might be resistance and compliance, which Dr. Rahman was probably talking about earlier. So we have those values right here to the right, where you have resistance, R, as 11.2, and CDYN, which is dynamic compliance, as 27.6. So that might be something you may want to assess. Okay, and I think that is all for the ventilator portion of it. So now, and that's the way the ventilator alarms. So if you hear that noise, that will be an active alarm that you will have to assess. Coming over to the V60 BiPAP machine that I spoke about earlier. Okay.
He said something just.
Okay, so that is what the ventilator will sound like when it alarms. Down here are the settings of the patient, and up here are your measured parameters. So those are things you might want to take a look at when it comes to one of the scenarios. Okay? And other than that, you may see me go in and out of the camera a little bit just to assist if you guys feel you need to change settings or just verbalize it, and you might see me come around in the background making changes to the ventilator, okay? So I'm going based on what you actually decide on when it comes to those specific scenarios. Am I missing anything else, Dr. Smith?
Camille and I do this with
the group one is ready for questions. You can start leading.
Okay, very good. You can hear me okay?
Yes.
Okay, during the simulations, I will prod you, I will quiz you, and if you're going off the wrong path, we will bring you back in. So let's do the first case.
One more thing. One more thing that I did forget. You'll notice on the ventilator that the patient is set up on 21% FiO2. If you need to increase the settings, just verbalize it. I may not change it because this mannequin is not able to take oxygen-enriched air. So you'll just verbalize it and we will take that into account.
Okay. You all see the case up?
No,
okay.
You have to load it.
Let's bring the case up. Okay, so we, first group, raise your hand. All right. What level are you? What level?
Super level, between 1 and 5. I don't know. They are between first year and fifth year. I don't know. But,
okay. All right. Okay. So,
second year, so 2 years of
could I see the
training.
case up on the screen?
Pulmonary. We can see the case. You can start.
Okay. So we have a 79-year-old African-American male who weighs 70 kilograms with a history of congestive heart failure, hypertension, diabetes, hypercholesterolemia. He's brought in by emergency medical services for worsening shortness of breath, respiratory distress. The wife states that 3 days ago he returned from Greece with fever to 101 degrees Fahrenheit or 38.3 degrees centigrade and productive cough. EMS has placed patient on 6 liters via nasal cannula, and the patient actually presents ill appearing in severe respiratory distress. Patient is speaking incomplete sentences. Respiratory rate is 26 and labored. Patient is noted to have nasal flaring and intercostal muscle retractions. He also has abdominal breathing. Medications include Lasix 40 milligrams twice daily, Lantus insulin 40 units nightly, and Simvastatin 40 milligrams daily. Family history, mother has diabetes and father has hypertension. He has no recent illness and no sick contacts. The vitals, I'm getting vitals for you at bedside. In the meantime, hold on. We'll get the heart rate is 109.
Pressure? I do not see it yet.
Yeah, the blood pressure is being taken as we speak. The heart rate is 109. SpO2 is 90. Blood pressure 170/60, and respiratory rate 25. His temperature, again, he's febrile to 101. His EKG? His EKG shows sinus tachycardia. I'll let you take a look at that for a second. Okay.
Yeah.
And this is his initial chest X-ray.
Okay. And people?
Can we see some focused echo, or is too much to ask? Initially.
I'm sorry,
Usually
could you
the
turn up the
focus.
volume? Yeah, go ahead. Can we see what, Dr. Theo?
Ejection fraction focus or something. B lines, A lines. Can we ask for this? For ultrasound?
The ultrasound machine is in use on the floor. It's not available at this time.
All right, so we'll go clinical.
It happens in real life.
So clinical exam. We have questions from the first team. Clinical exam, lung examination, heart examination, any abnormal sound exam or normal.
Okay. So heart rate normal S1, S2. He does have an S3, no S4. Lung sounds. He has bilateral bronchi, and it's decreased on the right lower field. He's again using intercostal muscles, respiratory intercostal retractions, abdominal breathing, nasal flaring. He looks overall very sick. His temperature, his skin temp is hot and he's sweaty, diaphoretic. And he is speaking incomplete sentences when he first comes in. So when he first came in, he was put immediately on BiPAP. His initial settings, very important for you to note, his initial settings were IPAP 10E5, and he was placed on 100% with a respiratory rate of 12. Okay? All right? You with me? Okay. So 30 minutes goes by, and you decide to do a blood gas. This is the blood gas.
What settings on BiPAP is the pH? Can you give us the session again?
Settings are 10/5, 100%, respiratory rate of 12. So first off, what do you see? What do you see on the blood gas?
Respiratory acidosis.
So they have the diagnosis of respiratory acidosis, low pH, high PCO2. PO2 of
Okay.
6.
Okay, what intervention would you like to do? What would you like to do?
Do we have any choices, or we have to come from our own to look on
No,
ChatGPT to see what
it's all you, doctor. This is your patient.
ChatGPT will tell us right now. I'm kidding. Let's see our clinical judgment.
All right. Clinical judgment. So, what do you have on blood gas? You said respiratory acidosis. What is the PCO2?
You wanna adjust? They are looking actually very good. They are looking to adjust BiPAP versus intubation. That's it there.
Right. So the patient at this time does not want BiPAP or does not want intubation.
10/5 is good enough.
No.
They want to adjust BiPAP a little bit, team number one. They want
Okay.
to increase IPAP. They said to increase BiPAP to get rid of that PCO2. They want to increase IPAP to 15/6, the new settings. Can we do it?
We can do it.
Okay.
Okay, Camille is increasing the IPAP to 15 as ordered. What other ways can you blow off the CO2 on BiPAP?
Few. No, few 21.
They want to increase FiO2 too.
FiO2 is 100%.
Let me look there. He's on 100%. 100%. Okay, sorry.
So if we only have BiPAP as an option, what other ways can we lower CO2? Yes, one way is to increase the IPAP, correct. What other ways can BiPAP offer us to lower CO2? Okay, Camille?
They want to adjust even on BiPAP if it's possible to give more time for expiratory rate. That's what they want.
Okay.
I'm not so sure. You give us the feedback.
Okay, so we can adjust the I time. How low do you want to, what do you want to change it to? I'm at 1 second right now. We can do 0.9.
They want to increase pressure support too from 15/5. You want the expiratory higher? Cool. They want expiratory to increase to 8, 15/8 or more.
No. 8 with 20.
So the new settings of BiPAP, they look on the patient and they went 20/8.
20/8.
20/8. Now, who said that increasing the EPAP? Which one of you said the EPAP?
Almost all
Okay.
of them. Almost all of them.
Okay, so the IPAP was correct. The EPAP, increasing the EPAP, Camille?
Well, actually, more focus on the oxygenation. So if oxygenation is not really our issue right now, you may not really want to touch the EPAP. But if oxygenation was an issue and you gave the recommendation to go up to 8, you guys did 20/8. You actually accounted for the pressure support, which was good. Because if you changed to 8 and you left your IPAP at 15, you now made your pressure support less. Okay, so you'll actually not be as effective on the CO2. So just to show you guys what I'm going to do, take a look at the pressure support right here. You see a pressure support of 10? If I go up on the EPAP to 8, what is my pressure support right now? Right. But someone did also say, let's do 20/8, which is okay, because now it gave us a pressure support of 12. Okay? So now you're on 20/8 with a pressure support of 12.
So that was very good, Team 1. You did very good. So you adjusted the IPAP and you adjusted.
Okay, that's about it. Oxygenation increased water, IPAP and CPAP, more linearity, has more pressure in the CO2 differential, IPAP, high, CPAP. That's how it goes. Yeah, they got the point. Thank you. Thank you, Camille.
Okay. All right. So
What else could they do? So there is one more thing that you could have recommended, which may not be part of these settings, but there might be another mode that we can use. You guys remember from earlier?
yeah, we talked. So it's on BiPAP now.
So do you want to go from BiPAP, CPAP to another mode of ventilation non-invasively? Yes. For things, let's say you don't want to monitor the pressures. It's another mode of non-invasive ventilation to put on this patient. What was presented?
Okay. So, did anyone say?
They said APAP. They want to try. They are not so sure, but they want APAP. So let's see.
Okay, so now based on the scenario that you received earlier, what would be a target tidal volume you would like for this patient? Let's start there.
70 kilograms.
Ideal body weight. Ideal body weight is a 69. Male or female? I'm sorry, we're trying to make male.
Okay, male. Male.
375. They
Okay.
calculated 375. They go blindly because they know male.
Okay.
Okay. So on ST mode, we were at a peak inspiratory pressure of 20 that you see right here at the top. So I'm going to select the tidal volume of 375. But if you come over here and you see this max P, I'm going to set it at 20. Doesn't mean it's going to stay at 20, because remember earlier I said this mode, it takes time for you to actually reach your target volume. So 20 may not be enough to achieve that target tidal volume. So we'll try 20 to start. We'll keep the minimum pressure at 10 because it is below the peak inspiratory pressure, so we may not be too concerned with that right now. And then the EPAP, we had an EPAP of 8, right? So we will increase that to 8, okay? And we'll keep the respiratory rate at 12. So we didn't discuss this earlier. Do you guys know on this machine, whether you're on ST on AVAPs, is your respiratory rate a true rate or is it a backup rate? What do you think?
Backup rate, the answer from here.
Perfect. Okay, so if your patient is already breathing at a total rate of 20, that respiratory rate of 12 is not active. If you do walk up to a patient and you see that, okay, the set rate is 12, they're only breathing at 12, that may be a cause of concern. And what I usually tell the residents here is just give the patient a nudge, call out to them, make sure they are alert. And if they are, then you know they probably were just sleeping. But if they do not respond, that will be your cause for concern. Okay? So now that we have all these settings for AVAPs, we'll activate it. Okay. So far, we're seeing a tidal volume of 332 at a PIP of 16. But it's still adjusting because you see how it dropped a little bit, so it will take time. So this is one of those modes where I tell my staff and also the resident team that spend time with the patient because we won't know what they do in the first minute or two.
So yeah, AVAPS is a very good mode, one of which they started using here in the last couple of years for those patients that are hypercarbic and you're trying to blow off their CO2. So in summation, you guys did a great job. You have a respiratory acidosis, hypercarbia, hypercapnia. You can increase the I time. You can increase the I time and the E time to keep that pressure support the same.
So, I mean the inspiratory pressure. So you can increase the inspiratory pressure to increase your pressure support. But if you do increase your EPAP, just take into account what your inspiratory pressure is so you can keep the same level or increase it further if you need to.
You can decrease the I time. And you can change mode to AVAPs. Sound good? Okay, group 2. Okay, group 2.
Group 2, câte fete sunteți? Voi 3? Okay, group number 2, they are ready.
All right, just give us one moment.
Yes, hold on.
Just making some adjustments to the settings.
Să recunoașteți PCO2 versus hypoxia, hypercapnia, vă jucați cu pressure-urile inspiratorii, expiratorii în funcție de hipercapnie sau hipoxie, da? Și acum nou mod asta să rețineți că puteți să dați aici minim și maxim presiuni să dai în ăsta mai normal. Și dacă le știți că asta reușiți să faceți doamna pe exemplu. Dacă nu-i COPD, mie personal ce mi s-a părut că s-a schimbat foarte mult high flow a schimbat practic-ul să se evita din There's no chemical scenarios.
Okay. Okay, group 2? Who's in group 2? Oh, hi. Okay. All right. So 30 minutes after putting the person, you've chosen all those modalities, but the patient's not getting better. The patient still remains sick. You decide to do another blood gas.
Yes, they said yes. They want to repeat the blood gas.
Okay. And that's your blood gas. That's your newest blood gas.
So patient responding to BiPAP or not?
Patient did not respond to BiPAP, did not respond to your changes.
Exactly, yes, yes.
And oh, by the way, on your clinical exam, the patient's getting more lethargic. Your vitals.
Are you showing the right ABG because it was taken at 8 and 1 minute rest day, and there was another one at 8:28.
Oh, the EKG?
No, the
ABG.
The ABG. Yeah. So the patient's. Yeah, the first one. You want to see the first one?
The second one.
That's the second one.
Let's say for the sake of simulation that we are doing here is the real one. Let's just pretend it's real. And what we're gonna do?
So the key there, what I'm giving you is the clinical exam. The patient's becoming more somnolent. The patient's getting more lethargic, not answering your questions now. What would you like to do?
What are you gonna do? They want to intubate the patient.
Okay, you decide to intubate the patient. Very good. So the respiratory therapist is by the bedside and says, "Doctor, what settings do you want the patient on?" 70 kilogram.
Settings for the ventilator.
What's your mode?
Tell Camille what kind of. They want to go by ideal body weight. So 400 tidal volume. If I were to be hypoxic, probably I'll go with they want upper level. What fragrance?
What mode would you like?
CMB is there, VC.
VC, okay. So VC, your tidal volume is what again?
400.
400 respiratory rate?
Good. 12.
12? What's your PCO2? Let's see the blood gas.
Translating a little bit, so they want actually a higher respiratory rate.
And why do you want
higher minute ventilation to compensate for that retention of CO2? They want to hyperventilate the patient as much as they can.
Oh, okay. And what PEEP do you want?
PEEP, what kind of 5 is good? Yes. Yeah, 5 is good.
Okay, 5. Okay. Camille?
So we have a rate of 16. Is that okay?
It's okay.
All right, 400. We have how much FiO2?
They want to go 60 FiO2.
60?
Okay. They send the same settings from the BiPAP machine.
Okay, so we will simulate as if it is 60. So pretend this says 60. And then we have a PEEP of 5. If you notice too, we're going to set the patient on flow. So there is a flow right now of 50 liters. Okay, so just take note of that.
We are increase it or increase a little bit?
You can hold off for now.
They want to increase it, the flow. They want to increase
I would hold off for now.
Okay.
Yeah, hold off for now. Okay, the patient is now connected to the ventilator, and it's just analyzing. Okay, so let's see, hold on.
Atașați un CO2 detector, se întrebați puteți, deci aveți luxury. They want to attach a CO2 detector if it's possible. I mean, they want to see the CO2 and tidal CO2, what the value.
Perfect. So if you take a look at the monitor, you'll see.
Can we have the monitor back up?
You see on the right corner and tidal CO2. Deci la noi la ventilatoare se pune și un end-tidal CO2.
Yes, you'll see the end tidal as 76, 79.
Okay.
That is your current end tidal.
Vedeți acolo? Ok, ca să știți unde vă jucați. În general, la și end-tidal sunt cam la fel, diferența e de 3 sau 4 kW. Am văzut de la în general, I'm just trying to make some more small comments here just in Romania.
Okay, now you said you wanted a PEEP of 5. Look on the vitals, and what do you still want that PEEP, or do you want to take off that PEEP, and why?
They are concerned about the blood pressure, but still they are probably 5. They probably they'll go with 5. I don't know. Do you want to increase it?
Do you want to increase it?
They want to put vasopressor for the patient. They want to sustain the blood pressure they want to keep people alive and not pressures.
Okay. Yeah. But the PEEP may hurt you because as you increase the interthoracic pressure, you decrease the right atrial return, and the PEEP may hurt you. Yes, the vasopressors might be indicated, but before that, the vasopressors, you may want to do the early goal-directed therapy, 30 cc's per kilogram of crystalloid, either lactated ringers or normal saline. Okay, 30 cc per kilogram. If there's no response, then we would go with vasopressors. Our typical first agent for vasopressors is Levofed, Norepi. Okay, secondary, it's vasopressin. But we go with, I think, an early goal-directed therapy, Levofed, either central line or peripheral. Okay? All right, so hospital day 2.
Per kilo, 30 per kilo. De cetrăutatea patient are 50 de kg, un litru jumătate. Are 80 de kg, 2,4 litri. 30 milliliters per kilo, that's your sepsis guideline. Give it in a septic patient.
Okay, so you've intubated the patient. You decide you've had a long day. It's time for you to go home. You hand off. You sign off to the next team, Team 3. Who's Team 3? Okay, hi Team 3. Team 2 has given you this patient that's had a somewhat difficult course so far. Now the patient's on pressor support. You've had antibiotics on, broad spectrum antibiotics. You suspect multilobar pneumonia. So you come in the next day and you have the nurse calls you and pages you and says, what do you say?
Doc, I'm having an issue. The saturation is dropping. As I listen to breath sounds, I hear wheezing, I hear rhonchi. I tried to call respiratory, but unfortunately they're unavailable.
Your vitals look like?
The patient is desatting. He's 87 now. His heart rate is 130.
Increase FiO2 100%.
Okay.
FiO2 increased to 100%. I'm still hearing the wheezing, Doc. I'm still hearing the rhonchi. I tried to suction, I get nothing.
Can we add some corticoids in the vein?
One more time, I could.
They want to give steroids.
Okay, you want a treatment? Albuterol.
Yeah. No. And IV2, one respiratory treatment and IV steroids.
And one question, does the patient still have fever?
Still febrile?
The patient still has fever. Can we bring up the volume? The patient still has fever.
Did we have some hemoculture from the blood?
No, cultures have gone out from day of admission. It's day 2. They're not back yet. No preliminary.
It's from the blood or from the secretion from the...
So sepsis workup, do you have anything positive on the sepsis workup? Blood,
No Yeah, no sepsis workup yet. The white count still remains about 30 with a left shift, high neutrophils. The morning chest X-ray has the morning chest X-ray has come. I'm sorry?
I'm not so sure if we did not hear it right. You try to pass the suction and you are not able of passing the tube?
No, I passed the suction, but I didn't get anything. But I still hear the wheezing. I still hear the ronchi.
Okay, wait.
The suction was able to go through.
Okay, can we have a bronchoscopy?
Pulmonary is not in the building. You called. Yeah, you called pulmonary. They're in the golf course. They're in the golf course. They're going to be coming in about 3 hours.
But what do you think of bilateral wheezing? Let me be brief a little bit here, Barry, just for that. Bilateral wheezing, still retaining CO2 68. What do you think is happening clinically? I'm trying to do a little bit on the half to see if you have the right diagnosis or not. You know which direction you are going.
We didn't ask for the normal history to see if the patient has COPD.
They are concerned if the patient is COPD or not, or asthmatic.
The patient was a poor historian when they came in. Family is coming in, but they're not in soon, so the patient can't recall. The morning chest X-ray actually came back, and actually the vent.
Okay. So
The vent is also alarming, but we have the morning chest X-ray, which shows.
On the side, go the other side. Okay, so if you take a look right now.
Yeah, let's let him look at the morning chest
Okay.
X-ray.
It is the same patient?
Yeah, again.
The question is the same patient which you started or you changed the patient?
Again, simulation is a little bit of suspending disbelief to being the same patient, focusing on the pathology, not the. It's a different patient, but suspend disbelief. Okay, that's the morning chest X-ray. Let's go to the vent, which is alarming.
Okay, so if you take a look, you notice how you have high peak pressures, and you heard it alarm, so it's alarming airway pressure high, right? So what are some things that you would want to assess on the ventilator? Is there anything specifically you would want to assess in terms of the measured values from the patient?
Why you have a high peak pressure?
Right, so let's take a look at, remember the additional values that I had mentioned earlier? Compliance, resistance. So remember we gave that the breath sounds was wheezing. So if we take a look at the resistance.
So we're just going to give you the values.
La rezistență pentru voi, la peak pressure. Ce ai spus tu COPD erai suspectat? Poate că asta este. They are looking right now at peak inspiratory pressure and plateau pressure. They would like to have the peak increase and plateau increase too. Can we do a plateau pressure? They want an inspiratory.
Okay, so let me try.
To answer your question, that's what we do right now. Plateau pressure, plateau pressure. Deep plateau, we have different pressure. So you ask on the situation. You ask on the situation.
So we're going to give you all the other measurements.
So plateau is plateau 7.6.
1 second. So one thing about this ventilator, once it alarms, it's hard to do a plateau. It cancels it out. So let's try it now. And I'm going to freeze. So our plateau is actually a bit on the lower end. So we have a plateau of 16, but look at the distance from that peak to your plateau. that will give you an idea of what your resistance is. And usually resistance is about 10 to 15. So it might be hard to come up. So your resistance right now is showing
Typically, what is the
33.
problem? What do you think is the problem? Alveolar or tubing problem? What do you think? They think it's a tubing problem. They suspect a COPD here right now, based on the data ventilator that you provided.
Okay.
Look at the waveform.
So now let's come down to our flow graphic. Okay. So if you take a look, you notice that the patient is exhaling, but not completely, and all of a sudden this next breath comes in.
So what do you think is going on?
Aircraft. That's the answer. Auto-beeping aircraft.
Okay.
Absolutely.
So very, very good. Very good. The X-ray shows hyperinflation. The patient is air trapping. So that's the easy part. What are you going to do, doctor?
Treatment of aircraft. They want to increase inspiratory flow to prolong the expiratory time. That's maximum that you can on inspiratory flow. You go to
Good
the
job.
maximum that you can do it.
Good job. That's one thing.
Okay.
They want to decrease the rate. They know their stuff. I told you.
Okay. So I'm going to point out something pretty cool with this Drager vent. If you notice, as I press the respiratory rate, take a look over here. It's already giving you an idea as you change it to what your exhalation time will be. So originally I was at an exhalation time of 2.75. What rate would you like to go to? Just give me a number. What would you like to go?
Respiratory rate.
13.
13? Okay. So now your exhalation time is 3.62, and then your I to E is 1 to 3.6. So now you've given the patient more exhalation time, and now they're having more time to exhale the CO2.
Good job, doctor. So you increase the exhalation time. Very good. Anything else, Camille?
That's pretty much
very good, team 3.
And I think they were right from the beginning when they wanted bronchodilators and steroids IV. I knew it was a COPD. So clinically, they wanted that broad-spectrum antibiotics. Definitely very good job.
Dr. Theo, you have anything else to add?
No, they recognize and I am prepping them out to keeping very, I'm impressed. They just listen right away. Too easy for them. That's my conclusion. You have to find more complicated cases. Go to the next level.
All right.
Otherwise, they're not using ChatGPT. I can tell you for sure. They're not using
Okay. All right. Well, the next level is not going to be given any hints. So, all right. Give us a second to set it up.
Let me know when you're ready, Camille.
Se uite pentru unul dificil, am văzut să vedeți un refractory ECMO, să vedeți ce se vedeți. Care a fost altele grafice? A fost foarte greu. Stabilitate, știi? Dar ideea era trebuie ținută în caracteristică.
All right, team 4. Who's team 4? Team 4. All right. Well, that team 3 had a good day on call, and they, but the patient, they told you about the air trapping, and they're patting themselves on the back, and they got the patient out of the woods there. So patient goes home. You come in the next day, and the nurse at bedside calls you and says what?
Doctor, we're still desatting for Mr. Sims. He is now 80%. I tried to call respiratory. I really don't know what's going on. And his heart rate is also increasing.
And of course,
How
you have
much
that.
FiO2? The question was how much FiO2 is the patient? He's on 100%?
The patient is on 100% still.
And of course, you have that family member that's outside the door while you're contemplating what you're going to do and says, "Hey, what's going on? What's going on with my dad? What's going on? What are you doing, doctor?"
Actually, you're right. That's a typical patient here sometimes.
So now you have an upset family member standing in the room and you haven't made a decision yet, and the patient's desatting rapidly.
He's down to 79, Doc. What would you like me to do? Would you like me to do anything to the patient?
Do you want an ABG? Do you need an ABG or that O2 set? Just let you know O2 set of 90 degrees equivalent.
Okay. The nurse has sent the ABG to the lab. The lab isn't back yet, but the patient is rapidly decelerating.
It's 80% now, Doc.
Doctor, what do you want to do, doctor?
What would you like me to do, Doc?
What's your next step right now? On the ventilator, refractory hypoxia on the ventilator with some values. You have a peak pressure of 41.
Doctor, that pulse ox is going down rapidly.
They want to check the ET2. They want to check the ET2 if it's in the right place.
The ET tube is in the right. The ET tube is in the right place. But now the vent is making.
Can you pass the suctioning? It's going biting the tube or?
Yes, I can pass the tube, but I'm still getting something beeping on the vent. It's saying PIP high. I really don't know what that means, and respiratory is not here.
Let's look at the vent, doctor.
And we're down to 69. Can I just bag the patient at this point because we're down to 69%?
So you have a high peak pressure. Do you want to know the plateau pressure right now, next step, or no? Do you think high peak pressure is secondary to resistance or something else?
We're down to 69. Can I bag the patient, Doc?
No, set it up. Your mindset, forget about it. They want to calculate to look on the plateau to see where do you stand.
Okay, we're going to calculate. We're going to do all those calculations. You're going to analyze the vent, but right now you have a patient that's going to code. So what do you want to do?
Bag the patient.
Okay, great. Okay, they're bagging the patient. Now we'll go to the vent. And,
easy bag. The question they are asking is easy to bag or is it
yes, very easy to bag.
Okay, picking up saturation.
Saturation's picking up. The saturation's starting to pick up. It's going up to 72, 75. Now we can go to the vent and analyze the vent.
What did they see?
What do you want? What do you want to see on the vent, doctor?
You want to look on the pressures again on the vent. What were the pressures? You had high peak pressure and they are not so sure if plateau was high or not.
Okay. So we'll give you all the measurements.
Okay, so your peak inspiratory pressure. Your peak inspiratory pressure was in the 40s. Okay, I'm trying to look for the trends because we do have the patient disconnected. Okay. I was getting lower tidal volumes, kind of down to the 350s, 340s. Peak pressures was 41. And the plateau was 18. But there's another value that we could assess. That was in the additional values. Do you guys remember? We assessed resistance on the last one. What is another value we might want to take a look at?
We want to check compliance. They want compliance. Take a look on the compliance.
Okay.
What's a normal compliance value?
Guys, what's normal? They said between 50 and 100 around.
Great.
Okay. So your compliance was 23.
Low compliance. Fibrotic lungs, big lungs, right? What are they gonna do? Still they are not so sure. It's easy to bag and you leak around the endotracheal tube, anything. They want to check the interface connection.
It's a little stiff to bag. I have to put a lot of pressure to bag, more than before.
They said they suggest to put a patient, if there's no problem with the endotracheal tube, they want an APRV to recruit a little bit more lungs, more oxygenation, go into ARD as more pressure.
Okay, so what are some settings that we may want to start with? So I gave you a plateau of, what was it, 23? 23, so keep that in mind, your plateau is 23, because you're going to set your pressure high, pressure low, time high, and time low. So your pressure high, we can start at the plateau, which was 23. So if you guys remember when Dr. Lopez gave his lecture, he said we like to keep the P low at 0. Because of the inverse IE ratio, you're further increasing the expiratory resistance for the patient, so you don't want to add on to that. So we always keep it at 0. Okay. And then your time high, usually about 4 to 6 seconds. So what will be your starting point? Anywhere from 4 to 6 seconds will be your time high, your inspiratory time.
What do you want as a time high? What do you want to start at?
4.
4? 4.
Okay, let's do 4. And then your time low, if you remember 4 to 6, you'll remember time low because time low will be 0.4 to 0.6. That will be your starting range. So what would you like for your time low? Your expiratory time.
.4? Sound good? Shake a head. 0.4? Okay, 0.4. Okay.
Shake your head.
Okay, so now we will reconnect the patient.
So while she's reconnecting the patient, what if respiratory therapist says, you know, doctor, I don't feel comfortable with APRV. You're on volume control. Can we do another mode? Because you know what? I'm just not comfortable with APRV. Can we do another mode?
Low compliance, ARDS type of patient. Think about the lectures, what we discuss, what you can. PEEP, they want to increase PEEP.
Okay, you want to increase. Who wants? Let me see. Show of hands. Who wants? Look at the blood pressure. Who wants to increase PEEP? Raise their hand. Who wants to decrease, or who wants to not increase PEEP? Raise their hand. Who wants to do nothing? Okay, so when you say increase PEEP, and you're looking at the blood pressure of 75/49, increasing PEEP in this particular case may not be the best idea because nothing in life is free. And so as you increase PEEP, it may help you with recruitment, but it's going to hurt you hemodynamically. So be careful with increasing PEEP on patients.
They want to change mode of ventilation. That's what they wanted. That's what they think it was the first choice. What's the title volume there? What kind of mode you have? I do not see it.
So our volumes, we're getting about 390, close to 400. Right here.
Camille, what about pressure control? Okay.
It's APRV. They did I think APRV, pressure control.
Yeah, which is good. But suppose you did not want to go to APRV, what will be another option? You can use pressure control as well. And what you'll do is when you're setting the pressure, start at that same plateau that you had of 23 and use it to see if you can get that same target volume that you guys selected as 400 earlier. If you're getting that target tidal volume with the inspiratory pressure of 23, then you're good.
So Camille, take them back to volume and
Okay.
then go to pressure control ventilation.
Okay.
So pressure control ventilation, if you don't want to do APRV in this case of a patient that looks like they're going into ARDS, you can do pressure control rather than APRV.
Okay, so I'll show you right here. We have PCAC, and we had a plateau of 23, so I'll start the inspiratory pressure at 23. I'll keep the same PEEP of 5 with the rate of 13, and let's accept it. Now take a look at that waveform really quick. Did you notice that that changed? Okay, so now we were able to limit that pressure, but the key thing that we're looking for will be the volume. So we had a target volume of 400. You're achieving on pressure control 380, 390, which is pretty much where you want to be. Okay, so that's another option as well. So whether you choose pressure control is fine, APRV is fine. It's more of a heightened level of ventilation, but it's a really good mode. I think we should be using it more often, especially for these patients who's in ARDS, but both ones will be perfectly fine.
And just keep in mind, we're trying to limit and reduce the barotrauma associated with ARDS. So if you started out with the 6 to 8 milliliters per kilogram, when you did the calculation, you may want to go to 4 to 6, and you have that, you know, for lung protection strategy, 4 to 6 mLs per kilogram, reducing the volume. Okay, permissive hypercapnia. I'm sure you've heard that. You know, we're going to give a little bit to get a little bit, and so you may want to reduce your volume. Okay. Do you want one more?
Blood pressure. That was the limiting factor for us. What are we doing? Fluid status. Do you have any value? Tank full or needs fluids or pressures or both?
Right, right. So you know, in this case, yeah, you're right, Dr. Theo. In this case, two things are going to go hand in hand. You're going to be volume resuscitating. You're going to be assessing the need for more volume. You're going to be assessing the need for an additional pressor to get that map up to what? 65, right? The map of 65 is what you want. Okay. Would you like one more?
Yes.
Or you're tired, or you want one more?
No,
Right?
nobody's tired here. Ready for
Okay.
action.
All right. We're going to have.
So let's
Okay.
take advantage.
Yeah, Dr. Theo, just have a conversation. We have to change something, and you can't see it. So Dr. Theo, just have a conversation with them, and we'll be right back.
And also, one moment. For the sake of the next simulation, I may put this patient back on volume control. So if you see that, it's the same patient. It's just that we're going back to volume control. Okay?
Okay.
All right, Team 5, you're going to be next. We'll be back.
Thank you.
Okay. Changing the suit.
All right, welcome back. Okay, team four?
Yeah.
Team four? All right, who's team four?
Team five.
Team five. Oh, upper level. Okay, so team five. Okay, so team 1, 2, and 3 went through the whole week with this patient. The patient has had a protracted course, went into ARDS, is producing a lot of sputum. The nurse is saying,
Doc, it's Mr. Sim again, and this time, I don't know, the vent keeps beeping, the PIP thing, and I'm trying to pass the suction and I cannot. I tried to call respiratory, but once again, they're busy. Is there anything that you would like me to do? And he's desatting to 74. Doc.
Do you want to see if the resistance problem versus lung problem? Next step, clinically and by ventilator. What do you want? Plateau is best resistance. They want to know the plateau pressure and the resistance pressure on the ventilator.
So unable to get that right now because your peak pressures are so high. So I'm not getting any readout on compliance or plateau.
And I'm trying to suction, but I can't.
They want to disconnect from the ventilator and back.
very good.
Sorry, you're good.
I can't bag this patient. It's so hard.
Blood pressure is 200.
I'm trying to bag.
Blood pressure.
Okay, how would you like to control blood pressure, doctor?
But in the meantime, we're down to 68 and I cannot bag.
Lasix. Can you give Lasix too?
We can give Lasix, but remember your ABCs.
I cannot bag the patient and we're dropping to 66, Doc.
You got resistance there. They want to check if it's something wrong with the endotracheal tube, I think. They cannot pass it. As soon as you said that you cannot bag is something that needs resistance. Can you check the ET tube for us?
I'm trying to suction, I can't.
What's going on the monitor? Interpret the monitor. Where's your CO2?
CO2, we cannot see the CO2. There's something wrong with the entire body.
Nothing's wrong with the CO2 monitor. Nothing's wrong, it's on.
They
CO2.
think it's some obstruction. They think it's some obstruction.
So what would you like to?
Something with the endotracheal tube.
So what would you like to do, doctor?
So what would you like to do?
Say it again, I'm sorry. So what do you think, what is the problem? Is the tubing problem? Or no? Ventilator. They think it's a tubing problem. They would like to check the tube if it's patent, obstructive, low, something there. They are not so sure, but it's something wrong with the tube.
Okay, end simulation. Very good, team.
They want to change the tube.
Very good. That's what we wanted to hear. Very good. And we are going to pull the tube out.
They want to do it in a safe way with bougie.
Very good. Very good.
We just discussed
Very good.
earlier difficult intubation. The ER doctor.
So as you see, there is a plug, a mucus plug in the tube. So that's why you had an obstructed occluded airway. So very good. You got to that diagnosis very quickly. I like the idea that you used the bag at the bedside and you went right for the bag. One thing we train the residents here is that next door to any ventilator, there's a bag valve mask. And if you have a patient that is rapidly deteriorating, rapidly becoming hypoxic, you know what? You take what you just did, take them off the vent, and you bag the patient. Camille?
And stay there.
You want to say that?
They want to raise the bronchoscopy. Still, that was the question. What is that for? Still evolving? What is it?
the pulmonologist, you keep ringing his phone, and he's on the 10th hole on the golf course. He's coming, but be patient. He's not in the building. So we're going to do a debrief now. And what we first do is ask you, all teams, you did a great job. Just go around telling us how you felt about the simulations. Team 1?
Yes. Feedback, debriefing. Useful, not useful, how you can improve it. Okay, first time, useful. Be confident, check it up and education. What you like for you to be done. Is something to improve in the clinical scenario or is good enough for your training? They would like to have it here. Let me put it this way. That's the general answer. And the answer is no. All of them, they would like to have it here.
Maybe next time, Dr. Theo, we'll go together.
You are more than welcome.
Thank you very much for your effort. It was a very, very nice day for us and a very new experience because we don't have some training simulation class here, and for us it's amazing. Thank you very much for your effort.
I just want to do you're welcome. You're welcome. I just want to do a round robin to give you guys feedback. You guys overall did a great job. Camille?
Okay, so just kind of walk you through what we had set up for you. So you originally recognized in simulation 1 that this patient was already on BiPAP, and you noticed that there's a need for increase in settings, right? So you increase your IPAP, you did increase EPAP as well, and then you decided, okay, at the end there is another mode in case this patient does not improve in your ST mode with the increase in IPAP and EPAP. So we shifted over to AVAPs as an option. So now the patient spent some time on it, but an hour later, patient decompensated and there was a need for intubation. So you chose initial settings, which was great, all right? You guys pretty much went alongside of what the ABG was showing, so that was good. And then we went into more of air trapping. So we created a little auto PEEP for you guys to visualize so the patient had increased resistance. I heard in the beginning you guys recommended bronchodilators and a couple, which was great. And in addition to that, you decided to increase flow and decrease respiratory rate, which was perfect. And then from there, we basically dropped the patient's compliance and made the patient in true ARDS, right? The patient was already trending there, but now you're in full-blown ARDS, and your decisions were, we could go straight to APRV, which was really good. We didn't expect to go that high already, but that was perfect. And then other options, if you did not want to go to that level, you still had pressure control ventilation to start, or you could have dropped the tidal volume to 4 to 6 mLs per kg. And then from then, that's when we switched out to the tube, to the mucus plug, which you just had. And you guys pretty much was spot on with that you said, okay, something is going on with the ET tube. So all of that was really good decision making. And I think, yeah.
And I want to thank our embedded participant, who is also a nighttime supervisor, who played the role of the nurse. So your feedback?
I just feel like when you're thinking about what you want to change to, just always consider the patient. How's your SAT doing? How's your patient heart rate? Because when we're trying to change into thinking to changing modes or to thinking about the vent, sometimes we forget the patient. So just take the patient off, bag the patient, then figure out your vent. Try not to figure out your vent while your patient is decompensating.
Exactly. Always remember ABCs. ABCs. Always goes back to ABCs. Well, from the West here in New York, we thank you very much. Institute of Neurology, Pulmonology. We thank you very much. And this was a great pleasure. Dr. Theo, we thank you. And I want to thank all our pulmonary critical care intensivists who participated in today and making this a very informative day. That's all we have on this end.
And a big thank you from all of us here. Great.
Okay. One last thing. We'll leave the contact slides up. We will give all the presentations to Dr. Theo. Will be made available. If you have any questions regarding the content, the next slide that's going to come up is going to have all of the emails and contact information, which we'll leave up there for you. Feel free to reach out to any one of them, and they will answer any questions you may have. Thank you very much, Bucharest, and from New York, goodbye.
So all the information you have. In the okay, perfect. Vreau și eu ceva briefing. Deci, în afară de hipoxie, ce alte terapii se mai pot face? Au fost PIP, au fost tidal volume refractory. Ce nu s-a spus aici? Non-ventilatory proning. Proning. Paraliticele vă mai pot ajuta la hipoxie. Și what's the last resort if you are în 7 zile cu refractory? ECMO, da? Deci ECMO during COVID îl pui imediat. Deci în primele 7 zile refractory ARDS, fail all the medical and ventilatory measures, still you go to ECMO, da? Deci toate nivelurile astea să le știți. Aici sunt toate cazurile să le faceți, n-am vrut să vi le dau dinainte ca să fiți challenge, le luați și prin ce s-a trecut cazele de simulation ca să le aveți să puteți să vedeți. Deci sunt, știu, most of the... Deci de research, dacă vrei și dacă... Asta nu știu dacă ar trebui să-i spun sau nu, dar dacă vă tentează rezidența peste hotare și aveți good recommendation, da, asta o să vedem oficial la nivel de instituție cum se poate. Și noi avem terapie, avem tuberculoși multatipică, aceeași patologie pulmonare.
Adică presupune că dai de bani, să intri în rezidenția, să mai treacă 6 ani, 3 de internet, pneumo și apoi...
Da, încă 6 ani ca să ajungeți aici. Cam ăsta e drumul la voi față de cât e ca să fiți cum sunteți aici.
Suntem în pâine, trebuie să...
Da, nu se echivarează. Am înțeles. Cel puțin ca schimb de experiență. Da.
Super rezidenți de anul.
Da, sunteți super rezidenți. Dacă veniți asta, știți acolo să fiți.
Oricum, haideți să luăm pasul unul pe care eu îl văd, adică vreau să mă plec în România, pentru că sunteți valoroși, pentru că toți România au nevoie de noi. E foarte bine că avem acolo români care au plecat și ne pot ajuta cu noi și vedem ce fac la noi. Deocamdată învățați voi, dar la un moment dat a venit momentul în care învățați voi pe alții. Și studenți și colegi care poate nu au avut acces nu au acces la informația. Haideți să ne ajutăm unii pe alții să facem mai bine.
Așa e. Mai ales acum cu tehnologia, cu Zoom-uri, cred că vine mai ușor. Asta a făcut COVID. Comunicarea. Ușor? Mersi. De aici?